So we wanted to talk about research and practice in the UK because we're all three of us are in two different organisations. We're all in With You, which delivers lots of training around peer support, and we're also in the Survivor Researcher Network. So when we saw the title of this amazing conference, we thought we have to be here. It's just right up our street. We really want to be a part of it. So thank you for inviting us and allowing us to be a part of that. What we're intending to do today, if my slides move on, we've got some slides just to talk about who we are. We also wanted to mention the UK context for peer support, just recognising the different language and the different situations we have between the UK and the US, just to make it clear about that. We're going to go through thinking about all this critically, because I think that's where we come from. We're not just sort of accepting what peer support is and what survivor research might be. We want to think about all this critically. And then we've got some examples of our work. So one is about thinking about peer support for lived experience researchers. One is thinking about lived experience research about peer support. So that's the sort of the two ways of doing it. And then also a great piece of work that Jackie led on, taking our approach over to Zimbabwe, which is why I'm so frustrated that that other presentation is running at the same time about the group in Zimbabwe. It would have been lovely to see both of them. We'll have to catch up with it on the recording, so I'm looking forward to that. So we'll introduce ourselves as we come to our slides, if that's okay. It just seems to be the easiest way around it. I think, Brian, I think you said that you wanted people to introduce themselves in the chat, so that if people wanted a certificate of being here or something, I think that's right. Presumably you'll put a link. Do you want to say something about that? Go on.
We're going to send, as far as the registrants, there will be an email that goes out next week, which will allow you to click on a link, add your name for to get a certificate. Just let us know which presentations you went to. Also, if you put your email in the chat, we're going to save the chat. So we're going to have that. Just say, I'd like a certificate. This is my email. And we can go from there. And also all the presentations are going to be recorded and they'll be available on YouTube most likely early next week. Okay, so, and we'll send an update to all the registrants from the email that you got earlier. Thank you. I'll let you take it away.
Thanks, Brian. Yeah, no, it's great that you're recording all these, although I'm terrified of being recorded and don't like that sort of thing, but I want to watch everybody else's. I guess the other thing to mention is that, yes, the chat will be saved and it will be there for everyone to look at, and it will be there for everyone to share and for everyone to download. So just being aware of what you're putting in the chat as well as something that we have as a sort of a rule in our groups, just being mindful of that. So let's move on to the next slide. I think I'm handing over to Jackie for this one.
Yeah, so I was thinking about our way into this presentation and how we were going to connect the two. And then I'm a great fan of Bell Hooks. I absolutely love and adore Bell Hooks for her criticality, for her experience, for her reflections. So she said, our living depends on our ability to conceptualize alternatives, often improvised. Theorizing about this experience aesthetically, politically is an agenda for radical cultural practice. And for her, this space of radical openness is a margin, a profound edge. Locating oneself there is difficult, yet necessary. It's not a safe place. One is always at risk on the margins, but one needs a community of resistance. So I'd like to think of With You and the work that we do there, and also Survivor Researcher Network Community Interest Company, as communities of resistance. So just to frame where we're coming from as a group, I think that is a fantastic quote to do that with. I think you're next, Karen. Oh, okay. So to say a little word about Survivor Researcher Network, Survivor Researcher Network supports service user, which may be a term that may not be used so much in the USA as it is in the UK. So that's just people who use services, and survivor researchers. So those are the two people that we identify with in terms of people actually being part of our network. We as a network aim to challenge marginalization of people. So we particularly want to work with people who experience exclusion and marginalisation within society. And there's a lot of people that we aim to engage in the process. So people with a learning disability, disabled people, people from the LGBTQI communities, obviously people with lived experience of mental distress, and people from different, who are racialised as Black and brown and from different cultures and backgrounds. We promote, we challenge the hierarchy of knowledge. So we really very much come from a place of actually bottom up, place of recognising that for us, lived experience should be at the top and clinical trials should be very much at the bottom. We promote evidence based on our own lived experience. So we will often use autoethnography and ways into our lived experience and creative practice that maybe others in more clinical places may not welcome. We promote alternative models such as the social model of disability over and above the medical model of disability. And we also engage with the model of madness and distress that was put forward by Beresford et al. In 2016. Will that do, Karen?
That's great, Jackie. Thank you. So that's one of the organisations that we're all involved in, and that's the Survivor Researcher Network. And we're also involved in With You. So we're an organisation that have been delivering training and consultancy around peer support in the UK for over 14 years now. It's been forever. And myself and Marissa are the directors of that, and we've built up this amazing team of associates. That is just some of us last year, a really sort of mixed group, and we like to work in that way because every one of those people and all the others who are not there, who are not represented, all have different backgrounds. So we're all coming from different interests around peer support, use of different services, different groups, whether it's groups, whether it's one-to-one peer support. We're working in different ways from mainly around England, although one of the people on that picture is now in Sweden and still works for us. So we've got a great team of people, but all with that concentration around peer support, with our roots in mental health, but also recognising that peer support is really important across a range of experiences and health conditions that it's suitable for. So we're reaching into lots of other areas as well. So that's our organisation. I will put a link in the chat later. Juggling slides in the chat is just impossible, but I have got a link with some of our social media links and all the rest of it, and I will pop that in the chat. Just because an international audience might not be as aware of what the UK context is around the policy. For us, in 2018, 2019, there were sort of very few peer supporters in the UK. I mean, it felt at the time for us, it felt like a lot. It was about, I don't know, 500, 900. It was a lot for us, and it's taken us a long time to get there in the start in 2019. Absolutely recognise that you've got a lot more over in the US, and they're in a very different place to us, which has always been reassuring. We've always been looking over to see what's going on here, what's going on in Australia, looking internationally to see how we can grow all this. We struggled, but in 2019 we had the NHS, that's the National Health Service, which is the national provider of healthcare within the UK. They had the long-term plan, and they decided to suddenly have this new ambition for lots of new peer support posts. So they wanted to go from about the 500, 900 that there was in 2019. They want to increase that to 4,740 by March 2024. So for us, that's a significant change in direction. It's a massive increase in terms of policy direction, but also in terms of the funding that comes alongside that. So that has been very welcomed by us. There's a list of services there on the left that it was originally intended for, but we've seen it go much wider than that as well, which it's been amazing. It's been an amazing thing to be a part of, this new enthusiasm around peer support in the UK. So that's where we are in the UK. And then also this next slide, just around the context of language for us, really recognising that I know that in the US, you use the language of peer specialist and certified peer specialist. I've done literature searches. It's been a nightmare trying to work out the different language. But we also ask questions in the UK about peer-based approaches, because we know that lots of people don't like that word peer support, because immediately, if you've got that label of peer support worker, you've immediately got that badge of lived experience, which in some services, people can feel that there's a lot of stigma and discrimination around that. So people suddenly don't like that word. So in our training, we ask that question around, well, what is a peer-based approach? What are the values that underpin that? And how do we approach it so that it's not just involvement or engagement? We're moving on to co-production, and we're moving on to that those values of equality, mutuality, reciprocity. So there's lots of language there. Some of it might seem that it feels straightforward to you. Others of it might feel very specific to the UK. But that's kind of the language that we're using over here. I think I'm moving back to Jackie now.
Yeah. So when we were thinking about the different languages and the different ways that we talk about what we do in the different spaces and places that we're involved in, we of course returned to bell hooks to guide us in that process. So bell hooks said, to teach in varied communities, not only our paradigms must shift, but also the way we think, write and speak. The engaged voice must never be fixed and absolute, but always changing, always evolving in dialogue with a world beyond itself. And I love that idea of us actually being in dialogue with a world beyond our own worlds, because we recognise the privilege that we have in the Northern Hemisphere, and that, coming from European backgrounds, there is very much that divide between what we experience in the Northern Hemisphere and what people experience in the Southern Hemisphere. So in relation to, very simply, language that comes from the medical model, the idea that we have mental ill health, as opposed to the social model of disability, which actually will bring our focus back to the context and the environments in which we are living and working and being. And, Hooks again said, dare I speak to you in a language that will move beyond the boundaries of domination, a language that will not bind you, fence you in, or hold you. Language is also a place of struggle. The oppressed struggle in language to recover ourselves, reconcile, to unite, to renew. Our words are not without meaning. So we very much want to recognise the differences and the commonalities that we share in terms of the struggles that we engage in, to actually think about things and write about things and speak about things in different ways to the people that often hold higher positions of power than we do.
Thanks, Jackie. I've got a slide here now to introduce Anne, and I'm so pleased that Anne's been able to join us.
Yeah, yes, me too.
And tell everyone about our fantastic link.
So we met on a listserv for peer researchers, because there is a global group of peer researchers, and when the peer researchers comes out, it's going to be wonderful. And I think in the UK, you do a lot of research about peers and about mental health that we actually don't even do in the United States yet. And so Karen and I met on the listserv, and we started chatting, as you would say in the UK, talking every week about peer competencies, and we just made it a weekly effort. And I've recorded them, and I'm actually putting those together now as a podcast, and you'll be able to get those on, you'll see it on choiceheals.com or casperconnects.com, KASPER. That's in the chat as well. And it is just a lovely time where Karen and I share what's going on in peer support from the different countries. One thing I learned is that they have rapid research teams in the UK, which we don't yet in the United States. We learn about different ways of approaching different populations, and also technology. We're going into ways of using different technology. And Karen, would you like to speak to our sessions?
Yeah, I just love speaking with you every week, Anne, because it's just, I don't know, it's just so inspiring. And I don't know, for me, it's always at the end of the week, isn't it? So it's just such a lovely way to end the week, and to learn about the similarities and differences, although we are so many thousands of miles apart. I mean, it's just wonderful that with technology we can keep in touch that way. For a start off, you know, we wouldn't have been able to do that a few years ago, would we? We just wouldn't have even thought about it. So to make those connections and to hear about each other's work every week, and I just have this lovely chat. I just love it. I'm really worried. I mean, the editing of our chats is going to have to be remarkable. I'm looking forward to the magic that you do with it.
It also helps me as a peer worker and also working in politics in the United States to look at the bigger picture, because it helps to look at a bigger picture. It's not as frustrating sometimes that it is just being in the small space here, because there's so many solutions we can find together.
Absolutely. And you travel so far as well, so hearing about all the different places that you've been to, all the different influences that you bring into that has been amazing. And also for me, I think we over here quite often think that America's doing everything first and we look to you, but actually some of the things that we're doing over here are okay as well. So it's been interesting to see what's missing for each of us, as well as what we can learn from each other. It's been great. I've really enjoyed it. And so thank you for joining us today as well, because one of the things that's come out of our conversations is around that language stuff, isn't it? About how you're like, oh, what is the NHS? I use all these acronyms, so it's been good to be pulled up about, well, what do you mean by that? What is that? With your background in an understanding of the words that we use has been so important for us.
Well, Karen, since you mentioned it, what is the NHS? And then we can go into the next one. What is the NHS?
I think I said before, didn't I? National Health Service. So it's the sort of the statutory sector, the one that's provided for everybody, free at the point of access, which is the principle behind it. So that's where we access mental health services, although there's a huge voluntary sector within the UK as well, which is kind of where we're, I don't know, that's where we like to see peer support. But it's good to see the statutory sector, the NHS, building up peer support. Should we move on?
Yeah.
We could chat, because I know that me and Anne could chat forever.
Yeah, and we could listen to you forever as well, because it's really interesting. So that's coming back in again, thinking critically about our practice, So I just, I know this has got bell hooks all over it, but I mean, if you're talking critical theory, I mean, to me, she's the person I would listen to. So she said there's an effort to remember that is expressive of the need to create spaces one is able to redeem and reclaim the past legacies of pain, suffering, and triumph in ways that transform present reality. I mean, we talk a lot about social change, but what we often don't do is learn from the past. So to me, bell hooks invites us to learn from those pasts. I'm thinking about particularly history that we have as colonial and imperial nations in relation to slavery and to the levels of oppression. I'm not proud of what we achieved in the UK in terms of the way that we dominated other countries and peoples and the things that we did when we actually invaded those countries. So in those ways, it helps to reflect on the whiteness and the privilege and the different ways in which we as a nation have really gained surreptitiously from the chaos and the oppression that we caused. So I very much look to people in Latin American spaces and places for me to understand oppression and what that means. And Macedo in 1994 and Paulo Freire in 1970 said that practice needs to firstly go beyond techniques. So it's not about the technique, it's about the process. And for us as peer supporters and as researchers, process is everything for us. To take account of the political, the social and the economic factors that marginalise and oppress people. So we know that worldwide, poverty is the single biggest factor in whether somebody will actually develop mental distress in the first place, but often that isn't spoken about in clinical and medical places. And we've got to involve theory, action and reflection to foster social change and social justice. So you can't have one without the other. You need theory, action and reflection to actually have any chance of effecting some degree of social change and social justice. And examples of this for me are things like the Recovery College, with you, I see as very much an organisation that is focused on that social change and social justice approach, and the Survivor Researcher Network. And we would like to think, though I think that's up to the people that we worked with in Zimbabwe, the peer supported safe spaces project that we're going to talk about a little bit later on. So there we go. I think that this is the lovely Sonia.
Thanks, Jackie. Earlier on today, I spoke with Jackie about what I was going to do, and she encouraged me to think and respond to this more informally. And I'm going to do that, Jackie. I'm going to do that. So I'm thinking about the fact that where am I coming from when I look at this area of work, which is about peer support, peer research, but also about research being one of the mechanisms for creating knowledge. And I've been a peer, been an academic, and I've been a lived experience researcher. So it's me, them, us, and I keep finding myself going in and out of these different roles. So if at any time I say they, forgive me, because it's actually me that I'm talking about with all of these things. And we always need to think about how we locate ourselves at different stages of when we engage in what we consider to be knowledge and its creation. And the issue is that truth and who gets to talk about what is considered to be knowledge and to be truth is a real site of tension and contention. And because academics have been in this process and social science has been in this process of argument about what is supposed to be valid knowledge and what's less valid knowledge. And, you know, it keeps reproducing, I would argue, quite similar information, I think, because there's a lot of pressure in terms of the UK, the research assessment exercise. A lot of people are writing different versions of the same paper over and over again. But for people like us who have experienced mental distress, we want knowledge that is going to make a difference. We want something that is going to be meaningful and result in change for people like ourselves. Right? So one of the reasons why the Survivor Researcher Network, Karen, Jackie and I are co-directors of it. One of the reasons why it was set up is to move beyond user involvement. Yeah, where, oh yes, we've been really co-productive. We've really engaged with people. We've produced a different sort of research. Oh yeah, where were the people who make use of services or who have experienced mental distress? Well, we asked them lots of questions. Yeah, or we've involved them slightly at the next level. We produce the entire research document and we ask them to reflect on it so that can become another paper. So, you know, we at SRN think it's absolutely essential that we move beyond just this mere involvement. And in our own document, our own manifesto, we say that this type of user-led or user-controlled research has grown and developed from the political roots of survivor activism that seeks to challenge the psychiatric system and collectively develop different forms of knowledge based on lived experience of mental distress, because we think it's valid. We think that's a valid knowledge or mechanism for developing knowledge that's going to make a difference. I don't think that is valued everywhere. And Sweeney argues that this approach, survivor research or lived experience research or survivor service user research, is different from traditional user involvement. If it wasn't, we would not be here, because we want to see something different come about. Now, what I want to do is to make a connection between lived experience or survivor or service user research and the world of peer support. because we think that there's a lot that can be drawn from it and that can be used to influence the research itself, but also the processes and mechanisms for supporting people with lived experience who are doing research to produce a better quality of research, because they are often being supervised by people who don't have that background and don't necessarily value the knowledge that can come from that source. So in terms of peer support, in the UK, which is what I'm going to talk about because that's what I know about, when I did research with a national organisation called Mine back in 2013 and again in 2022, what we found was that there's lots of different forms of peer support that is existing out there, but people don't necessarily recognise it as peer support. They don't recognise that language. They often talk about self-help, and I know there are all sorts of issues around that language, but that's what they see it as. And it works like this. Oh, I can't get the help that I need from the public sector. That's governmental organisations. I've got this issue. I need some support or some help. Oh, they don't have that service. I'll go and look in the NGO sector or the voluntary sector. Oh, they don't have it either. I'm going to have to set it up by and for myself and other people who are like me, who also want this service. That's self-help. And that's the sort of peer support that's been existing for a long time in the third sector, voluntary sector, NGO sector. And it's really good at doing intersectional work. It's really good at creating these really small groups of spaces of safety, confidentiality, and support and belonging. Okay, so you might find, for example, a group that has been set up specifically for members of the LGBTQ community to support one another. They're all over the age of 50 and they live in a specific city. Yeah, so that they do lots of intersectional work. So let's move on to the next slide. Thank you very much, Karen. So as I've been saying, there's a lot of pressure on academics to produce research, but the quality of the research or the quality of the papers, I would say, can be questioned. Whereas I think because more people with lived experience are actually entering academia and looking specifically at the issue of mental distress and services for people who have experienced mental distress, they have the opportunity and the means to be able to create new knowledge, better quality knowledge that is more connected with phronesis, which is a type of wisdom or intelligence relevant to practical action and which generates responses to questions such as, where are we going with this specific management problematic? Who gains and who loses? By which mechanisms of power? Is this development desirable? What, if anything, should we do about it? Okay, so they're very focused on and very motivated to make a difference because they think to themselves, I want to make sure that other people don't go through the experience I went through. I want to make sure that there is something different and better than what I experienced. And I want to be able to leave knowledge behind that is going to generate the difference that is meaningful. Okay, so with all this in mind, we argue that researchers with lived experience of mental distress are coming at this issue from a different lens, or they have different insights that others don't because they haven't experienced the same things. That they're in a great place because they've been on their own recovery journey, and there's skills that they've developed by going on that journey in terms of learning and identifying patterns, particularly around issues to do with mental distress and mental health services. They'll be useful for creating knowledge, and they're more likely to emphasize flattening the relationship between themselves and the people who are involved in their research. They are more open and willing to do co-production, and that in itself creates a different quality of learning than you would get from many traditional models. So they move beyond ontology, epistemology, methodology, and method to more of a phronesis in terms of their approach. Next slide, please. Okay, so peer mentoring. So in SRN, we offer a service which is about supporting people who are survivor researchers, lived experience researchers, etc. So what we want to do is to make sure that we can support people through the experience of doing their research, that whole process, because they often find themselves being stigmatized. They often find that their knowledge isn't being recognised, that they are being the label of having lived experience often supersedes their skills, or seen to supersede their skills, their knowledge of being researchers, and they're often seen as too weak to complete the research or do the research, or they are too open to being subjective. Their knowledge isn't seen, or of their lived experience is seen as actually being a weakness rather than a strength. And yet they are expected to, with all that stigmatization, to be able to enter a supervision relationship and to be challenged and to have a reasoned discussion around the creation of knowledge and that research process. So that is one of the reasons why we offer peer mentoring. If you could just move to the next slide. Okay, thank you very much. Okay, so they often come to us asking about how they can center themselves in the research process under such circumstances as stigmatization. How can they do that when their confidence is being damaged and their critical voice is being set off by the fact that other people already are undermining them and questioning whether they really know what they're doing, or whether they have the skills, or whether they really are researchers at all. So people often come with their confidence being highly damaged. We go to the next slide, please. Okay, so what we feel that we can do, and what we have been doing, is drawing from the work of Paul Gilbert, who talks about the 3 emotional regulation systems, and using that for resilience-based supervision. So if you think about this as these are being the 3 main drivers of our thought processes and what might lie behind our behaviours. There's the threat system. We all recognise that: fight, flight, or freeze. We often feel that when we are in danger, perhaps sometimes when we're angry, or perhaps disgusted about something, or may even be feeling jealous. It's a very powerful system. It's very ancient. It's what kept us alive when we first became humans and were walking around, and many animals looked upon us and thought we looked delicious. So we did a lot of running and hiding, and we lived in fear. Yeah, so that system kept us alive. And for those of us who didn't have such a good system, we have been taken out of the DNA pool. Okay, the rest of us, that system is there and it will spark off. I don't know about you, but I don't see a lion walking down the high street very often, but that system will spark off when it feels threatened. And then we have to think about how we're actually going to manage that. And we should be able to do that through, for example, breathing exercises, being mindful of where we are, and getting our system back under control. And then there's a drive system, which is about what motivates us. And obviously, the people who are doing this research are incredibly motivated by the idea of being able to make a change with the research that they do. Yeah, so they're ambitious, they're driven. So it's a shame that they don't have the opportunity to be able to make use of that drive system, because their threat system is so often being sparked off by people who are stigmatizing them, people who don't expect very much of them, going into a room with a supervisor who then says, "Are you sure about that? Sounds a bit subjective to me." Yeah, so we work with this system and with the values of peer support in terms of self-determination, in terms of mutuality, in terms of respect, equality, to explore all of those issues, to encourage people to think about what might be driving the threat that they're experiencing, the emotions that they're feeling, to think about where they're coming from, how they can use their soothing system to go back in and have a reasoned discussion with somebody who's stigmatizing you. Yeah, so those are all the sorts of things that we do within our peer mentoring relationship in order to be able to support people, ensure that they feel safe in terms of the confidentiality and the trust. And of course, we have our own shared experiences, so we're connecting across vulnerability. And we always make sure that we do a checkout, and the checkout makes use of the soothing system. You know, what are you going to do for yourself in order to look after your well-being? And the drive system, what actions are you taking away, having had this discussion with us? So you can see clearly we can make use of both the resilience-based supervision model, which is used within peer mentoring, and also the values and principles of peer support in order to be able to support people in ways that are meaningful to them. So, thank you. So I've finished. That's me over.
Can you
Thank
hear
you.
me now? Yes.
Yes, we can hear you.
All right, I just wanted to make sure whoever is next, presenters, or if you'd like me to do anything or help out. Thank you.
Yeah, we've got a few more just to talk about the.
Yeah, we've got a few more. I was going to carry on through. I was just struggling, having managed to mute myself successfully and share the slides. Unmuting was like a step too far then for a second.
Yeah, we don't want to overload people with PowerPoint, but we have got a little bit more to go.
Yeah,
Darren, can I ask Sonia a question?
Of course, yeah, of course.
You brought up the word, a couple words here, mind. What is mind in the UK? Maybe explain.
I apologise. Mind is I would say the most well-known national NGO that supports people who experience mental distress. They do a lot. They are
they're a franchise.
Franchise, that's it. Well, perhaps franchise isn't the right word, considering it's not a private sector organisation. It's a word I think Americans use a lot when you talk about the different states.
Oh,
yeah. I'll remember the word and I'll put it in the chat. But basically, they're all independent organisations, but under an umbrella, and they are all different all over the country. I think it's something like 140 of them. There's a lot of them. They also have their own charity jobs that also feed into the organisation. So they do a lot of projects all over the country.
Yeah. But because they're all different, the quality of what you get is different in different areas.
Right. And then you also talked about something about co-production. Can you explain what co-production is in the UK?
Yes, it's about sharing power with people. So all along the research process, you would look for ways in which you can empower people that you're working with in order to be able to improve the quality of the research that you're doing. And having worked in academia for a long time, I see why people struggle with it, because the power differential, there's just so much invested in, you go into university, I'm a lecturer, well, I'm a senior lecturer, well, I'm a senior lecturer, I'm a principal lecturer, I'm a principal lecturer, well, I'm a professor, I'm a professor, well, I'm an emeritus professor. That hierarchy, that rank is absolutely solid within higher education, and obviously that's where so much research takes place, and people struggle with co-production.
Yeah, having said all of that, Sonia, because I'm currently doing a project where I'm working with people with a learning disability, and we are a tiny little arm of a very big project, and we are doing co-productive work in that we've got an advisory group that's made up of people with a learning disability, We've got workshops that are co-led by people with a learning disability and myself and one of the other workers. And we're using creative arts-based approaches so that everybody can participate in that process. So I think it depends on how invested the research team is in actually co-production happening in a meaningful way.
Thank you. Is that explained, Dan? That we okay? Thank you so much for keeping us on track. Because we make so many assumptions about the language that we use, so it's really helpful. Yeah, thank you so much. Thank you, Sonia. That was talking about how we provide that peer support for researchers as lived experience researchers, survivor researchers. And so I've got a couple of slides here about how we do the research around peer support. With you, we're always encouraging any organisation that we work with to think about that baseline data at the start, because you kind of want to show the difference that something's made. So you kind of need to know what's going on at the start to think about how things are going to improve going on. And while we do that, we also end up working with evaluators that those organisations might bring in, and quite often they go straight for that independent evaluation with traditional academics who, to be fair, often don't understand what peer support is. They might have a great reputation, but they don't understand the sort of the nuances, the subtleties around peer support. They don't understand where it's come from for the last 20, 30 years. They're going to have to read the literature on self-help and peer support, but they don't have that sort of fundamental understanding of it that really helps us speed up with the language and everything else. They don't understand the different approaches that might be within peer support. So I think Sonia referred to, all those different ways that different communities and different groups might look at peer support, the language that people might use around self-help, around mutual support, just being with each other. People don't necessarily use or understand what peer support is. So bringing in these external evaluators has sometimes been quite a challenge, really. They have a focus on measuring stuff, so they really want to know those outcomes, which is why we insist on encouraging people to think about that baseline data as to where they're starting off from, because we know that people will want to know what difference something has made, and they'll want to measure it. They'll want to put it in a bit of a box to take it forward. Whereas when we've worked with survivor-led organisations and people who really understand what peer support is, we can see that there's often quite a more creative approach to things. People understand what we're talking about and don't assume that all peer support is the same. So rather than measuring the difference that something's made, we find that survivor-led organisations are curious and want to hear about the experiences. They want to know about the meanings of what's going on for people, and they want to explore the uncertainty that's involved around peer support, and they're not frightened of that uncertainty either. They're used to being flexible, being curious about all this, and I think from not being surrounded by and immersed in the mental health system, survivor researchers can approach things from a different angle and just think differently about how to evaluate it. The unfortunate thing about that, though, is that all the funding, all the prestige goes to the academic researchers, the established researchers, who measure stuff, and that influences policy and practice, in that for their research studies, they might have to measure a very specific intervention, whether that's with a specific group of people or at a specific point on someone's journey into or out of services, for example, is a usual one, or a very specific group, a specific way of doing things in one organisation. The research might look at that, develop the evidence that works, and then that goes into policy and influences what the rest of us then have to do, because we know that very, very specific thing works, which is frustrating for us, because then that gets labelled as peer support and it ignores all the other types of work that might be going on. Whereas our survivor-led research tends to be of lower priority. We might ask different questions, but they might be perceived as less important. So an example that I want to go through pretty quickly, because I want to get to Jackie's example, which I think is more inspiring, and I want to hear more about it again. So the example I wanted to bring was from my PhD. So as someone with lived experience in 2015, I was seeing that a lot of managers were saying, well, peer supporters can't use computers, they don't use technology. Thinking, but they do. We know that that's not true, and we know that everybody is. We know that we've seen people using YouTube and all the rest of it. We know it's there. So for some reason, I wanted to explore this. I could see that I could see that tension with what people were assuming about people who were working as peer supporters. But the traditional academics weren't necessarily asking that question. The first thing that you do when you do a PhD is to sort of do that literature search and see what other people are doing, see what the existing knowledge is. And I could find a lot of information about, and lots of people looking at, whether people with experience of mental health challenges were using digital technologies, whether people with very specific diagnoses had a mobile phone or a cell phone, I think is what you call it, isn't it, Anne? Sorry. But just seeing whether people had that, whether people were accessing it. But as people with lived experience, we knew that people were, we could see that people were sharing information online. We could see that people were uploading their experiences to YouTube. We kind of knew it, but the traditional academics were still questioning what are people doing? Can they actually use a mobile phone, a cell phone? So I had very different questions from what they might have been asked, what the traditional academics might have been asking in the first place. I've just got this slide, which has got a couple of phrases that came up in my study, which I thought were quite interesting and quite useful perhaps to mention here. So that first one at the top there, the mediated by peer supporters. There's a report out, it's called the WISH report, which looks at how we use digital mental health, and it divides it into two groups, one that is mediated by consumers and one that's mediated by the healthcare system. So thinking about sort of the apps that we might all have on our phones, that's mediated by consumers. We've got control over that. And then the mediated by the healthcare system is perhaps the stuff like, I don't know, patient records, stuff like that. And we know that peer supporters are doing both of those. But when I was researching it and speaking to people, I could see that they were also doing stuff that was in between. They were very flexible about things. They were taking apps and making new uses of it. They were being very flexible to the needs of the people that they were supporting. And they were sometimes quite frustrated by the systems that the healthcare system was trying to make them use. So, for example, they were being asked to use Teams, and they were finding that didn't work with the groups of people that they were working with. So they were sneaking in a bit of a use of Zoom, for example, things like that. Sorry, all the trademarks of this, but I'm sure they're international nowadays. So I added that category of mediated by peer supporters to really emphasise that peer supporters do have and do want choice and control over the technologies that they're using. That second phrase at the bottom around navigating their world was a phrase that came up about what peer support workers are doing. So there's this in the literature, people want to kind of put it into a box and try and get real role clarity about what peer supporters do. But from speaking to people, it seemed to be just about supporting people to get around their world, sort of sitting alongside people, listening to them, supporting them, helping them to make sense of everything. And that included a digital world, supporting people to use technologies where needed. For example, over here, the welfare benefit system, all those systems are now digital first. So it was about supporting people to use things like that, if that was their choice. But they also had a real role to play in advocating for choice within the system for people not to engage in that digital world. So those two small findings from my study, I think, were quite important as we're coming against that pressure within the UK, certainly, to define the role clarity for peer support workers. I think that's one example. My study's been one example, really, of how lived experience is important when we're doing research on peer support, and not just leaving it to traditional academics who might not understand that specific field. I think my frustration with it has been about that lack of funding that's available for lived experience research. At the start, I was really idealistic about it, and I wanted to do a participatory action research study, making sure that we'd included peer supporters. And I knew loads of peer supporters. You know, I'd come from that lived experience perspective. I thought doing the kind of participatory action research would be relatively straightforward. But straight away, I came up to that conflict and tension when, as an activist, I'd been fighting for people to get paid for their involvement, and all of a sudden there was no funding for participatory action research. It was a real challenge. So I found, the barriers were far too high to get people in. I just worked against everything that I stood for. So I ended up falling back on doing interviews. So that's one study. And I want to hand over to Jackie and the amazing work that you were doing in Zimbabwe, which is far more interesting than that.
Have a word. Actually, I was just thinking, you've given me a real heads up for that interview tomorrow. So I'm
Let's be of service.
Good on you, Karen. Yeah. So I wanted to take a little bit of time to share one project that we did, which was a collaboration between myself and my best mate, Abby, whose full name is Abby Sesulelo Ndlovu. And she is a wonderful woman from Zimbabwe. And I'm really sorry that she can't be here with us today. But unfortunately, Abby does live in care work. So she's actually at work at the moment. So we called it Peer Supported Safe Spaces in Zimbabwe because it came out of Abby and her family's unmet needs in terms of one of their relatives experiencing mental distress and then being stigmatized because of their experience of mental distress. So Abby and I were having conversations for quite a while, really, before we approached with you and said, give us some money, please give us some money. We're going to Zimbabwe anyway, because we were going to see family members and to reconnect with family members. So we said, can you give us a little bit of financial support? So I'm going to talk a little bit about what we did and why we did this. And then, so what did that mean for us all? And then now what do we want to do? And the what, so what, now what is one of the examples of reflective practice that we use within the peer support worker training that we deliver it with you. And it extends over into the Survivor Researcher Network because it is such a good model for actually thinking about and reflecting on the practice that you've done. So if we could go to the next slide, please. Thanks, Karen. So this is what we did and why we did it. So originally it came out of a need, an unmet need from within the family. We had that partnership already established between with you and the Survivor Research Network. And the first time that I went to Zimbabwe with Abby, we made connections with Sigola Primary School, which is in the rural district in Bulawayo. And we actually just went and had conversations with people and asked them what they needed. And they very much told us what they needed was technology, that a lot of the young people within that school were not going to get the jobs that they needed because they were already in this one down position from all the kids that were in schools that had computers. So luckily, between the two of us, we managed to donate some monies to the school so that the young people themselves could actually use computers and get online and have some of the access that we have in the Western world. So when we went back, we went to the clinic as well, and we met local people and local groups, and we had those conversations. So when we went back, we'd already approached the teachers in the school and said, look, we deliver peer support worker training in the UK. We were wondering, is that something that might be of some value to you? And they were like, yes, bring it on. So the first day that we were supposed to deliver the training, the car broke down. So we had to renege on what we were doing, and it was really hard because we felt really bad about it. And we thought nobody was going to enroll and that nobody would want to work with us because, we were seen as a bit incompetent. The opposite was completely true. We had 35 people, teachers, clinic workers, and also young people, importantly, young people from the Esigola rural district in Bulawayo. So we were like overwhelmed that so many people wanted to do the training. We delivered days 1 to 4 of the peer support worker training from with you, but what we also did was culturally adapt that training to the needs of the people that were undertaking it. So Abby speaks Ndebele, she speaks Shona, she speaks a range of languages. So she was communicating with the people, and we had a little core group of people that were helping us with the organisation. Christine Chiwadza, who was one of the teachers at the primary school, and then the deputy head at the primary school as well, let us use one of their rooms so we could connect to the internet. I mean, they literally went above and beyond for us. We had women coming to, there was a group of women that cook lunches for the kids in the school. So we had some funding from With You to be able to provide us with the firewood and with the monies for food so that we could cook on an open fire. And then after the training, everybody had a meal and shared that meal together. And that worked really well because at least people were being fed while we were doing it. So we were inconveniencing people as little as we could. And we included human rights training in that we have an experiential exercise that I've used in the past with people with a learning disability that actually explains to people what their human rights are and then invites them to reflect on that from their perspective in relation to which of their human rights has been negated throughout their life, and to share that as a group experience. And we also explored madness, so mental distress, but you know, I identify as a mad woman. So we explored madness and mental distress and mental ill health from those cultural perspectives. And there's a word in Ndebele, which is flana, and flana basically means you're mad. And that was the only word that we could identify within the Ndebele language. So in a way, it was like the group of people that we were working with had to decide upon their own words, and they wanted to use words that were more positive and less negative in terms of framing their distress. And then when it came to evaluating the process, normally, Karen will tell you, we have a few questions that we ask of people in our evaluation process. But we didn't want to be quite so formalised. So we wanted to know what people's past experience was, what their present experience was, and what was their hope for futures, because we wanted to continue this project on and know what people wanted in the future. So for my PhD, I co-designed a body mapping evaluation tool with a group of people that were running a community-led organisation that was led by people with lived experience like myself. So if we could move on, Karen, we're going to show you the tool that we used. Oh, there's the people, yay! So Abby is the person sitting in the front with the green t-shirt on, and you can see, I mean, we had just a fab time. It was absolutely such a blessing to be there and meet everyone. And I think we formed relationships that are going to last, you know, over a lifetime, really. And such impressive people. My goodness, you know, to survive, you know, the cost of living is massive. You have to go looking for firewood every day. There was kids outside our gate were actually whispering to each other in Ndebele. There's a white woman washing pots and washing clothes, and you know, it really is not an area where white people have been. They've been very privileged, and they've taken advantage of the people there. So I didn't want to bring my white privilege to that situation. I actually wanted to muck in and work with the people that were there. So, you know, I washed pots, I cooked on open fires. I did all of the things that everybody else did because I really wanted to bring myself to that level. But I created a bit of a stir. So you know, the kids were brilliant. They just laughed at me and I laughed along with them. So the next slide, if you don't mind, please, Karen. Thank you. So this is the Be Me tool, and it's very much about what it is like to be me for those individual people that completed it. It starts at your right foot, what are your roots, where do you come from, what's your country and your family of origin, what your experience is, good and bad. Then it goes to your right leg, which is about the journey that you travel to get to where you are now. Your right arm are the skills and abilities that you brought with you to the process. Your right shoulder are the responsibilities that you had before you came into that process. Your vision is what drives you and how you think the world could be better. Your mouth are the criticisms and the comments and your thoughts about what we're doing and how we could do that better. You left shoulder of the responsibilities that you might have taken on in the project and as a result of your involvement. Your left arm is the skills and abilities that you're gaining now or you want to learn and share in the future. Your heart's what you love in your life and in the project, if anything. Your stomach is the happy, sad, angry, scared feelings in your past, present, or hoped for future. Your left leg is the path that you want or hope to take in the future, who you're going to travel with, how can we support you in getting there. And your left foot is ultimately where you might like to end up. And are we helping and supporting you or not in getting there? And if we move on to the next slide, you can see an example. We had 33 BMEs completed by people in the group, and they were all very varied and very different. And we collated all of the responses that came from the part of what do you want to do in the future. And what we ended up with is the next slide, which is 23 people wanting to do days 5 to 8 of the peer support worker training. We have some money left for that we're sending to Zimbabwe so that people can purchase their own tablets, and where the school itself can have those tablets and laptops so people can access the online training. 9 people want to start a peer support worker training organisation, so they want to go out and deliver training within their own communities and have an organisation that they can attract international funding with in order to pay themselves to do that. People wanted funding for resources like laptops, phones, books, transport and internet, and we're trying to do our best to gather like second-hand phones to take with us next time that we go. We've already provided some laptops, but if anybody wants to make a donation, we'll happily provide more. And we recognise that transport in terms of people actually getting to and from the training or getting to where they want to go to deliver the training is a big problem because it all costs money. And the internet as well, with you, has given us some monies so that the school itself can have internet access, and that can help us to facilitate the online training of days 5 to 8. And they also want to train the trainers programme. And we're going to have to work with the community in order to culturally adapt that so it meets the needs of the community, given that they're in the Southern Hemisphere and we're in the Northern Hemisphere. So that very much is where we're hoping to go in the future. And there are a number of people within With You who deliver training who volunteered to be part of that process. So that is fantastic, really. It's a win-win, I think, for us all. And I think that is the last slide, if I'm right, Karen. Oh, there we go. So email addresses and websites. So thank you very much for listening. And I'm sorry that it's been such a long process, but we'd really welcome and invite you to ask any questions, any thoughts, any reflections, and to share with us what you think. You may have very different experiences, and we'd be delighted to hear them.
I'd be really interested to hear and put you on the spot.
Go ahead, put me on the spot. You do that, Karen. Yes, this has been marvelous. You've not only given about the whole thing about research, survivor research, but also tools to use too, the Be Me. That's a wonderful tool. I had a question about why is it important to do peer research and what do you use it for? Here in the United States, especially in California, where this organization SHARE is, so a lot of things changing fast with mental health, even people's rights. And I know here that the politicians use the research to base their information and decisions on. So it's very important to get the research out. How about the UK? You've done such a marvelous work on research. Why is it important?
Oh, but I mean, for us, it's important because without the voices and the experiences and the needs and the understanding of the people that we engage with, you know, there's a whole raft of people in the UK that just don't even begin to get it. That, you know, they put themselves in this one above position. They do not recognise that 1 in 4 of us at some point in our life will experience mental distress. And until it is brought to their attention, and also brought to their attention in terms of the actual diverse groups of people and their unmet needs, very often, you know, the amount of money that gets spent on mental health as opposed to physical health is minuscule. You know, so in a way we have to fight those top level policymakers for them to really understand where we are coming from and how they need to support us in making things better, and not necessarily put more money into clinical services, but actually, you know, we can give better value for money and we can make more significant changes with far less resources in the third sector than you would traditionally need within the National Health Service.
Absolutely. And the quality of what we do, the direction we come from, what we want is different. A lot of academics, their main priority, let's be honest, is writing the next book, writing the next chapter, producing the next paper, becoming a professor, increasing the type of professor that they are. Our priority is different. Our priority is that we want things to change. And so, you know, we've just got different emphases. The things that we think are important are not necessarily the same things that they think is important. So we're going to produce different research.
And also different questions. What you focus on is different too, right?
Yeah, completely.
Absolutely.
Yeah. But I mean, for us, it's very much bottom up, whereas a lot of clinical practice is top down. So as a critical community psychologist, my job is to ally myself to people from minoritized groups and communities. I don't ever diagnose anyone, including myself. So it is very much about allyship. You know, so it's a completely different way of working. There's a fabulous guy called Ignacio Martin Barro, who was a Jesuit priest and a social psychologist who worked in El Salvador with Salvadorian peoples. And there's a collection of his essays called Writings for Liberation Psychology. And he said, we should take the whole of psychology and turn it on its head. And then we should ally ourselves to excluded groups and oppressed groups and communities. And then we should aim to look up together from there. You know, so for me, Ignacio is where it is. And I was introduced to Paulo Freire by some people from Latin America while I was in a conference at Bath Spa, and went to Bogota, went to Colombia. You know, to me, it's like there's an arrogance in the Western world. We think we invented everything. And we didn't, you know, so it was like completely opened my eyes that, oh my God, this is the entire universe out there. And nobody had ever mentioned it to me. So I'm like hooked. Ignacio's my man. And Paulo Freire was a white middle-class man. But, I mean, he wasn't perfect, you know, from a feminist intersectional perspective. But a lot of what he said about the banking system of education and the critical education, and how we're not empty vessels, but we come with our own lived experience and bring that to the process. You know, I rejoice that you said it.
Jackie, just to let you know, in the United States, a lot of community health worker trainings and thinking comes from Paulo Freire. I also wanted to ask about, you brought up the social model, and in Europe, I don't know where UK stands. Are you part of Europe now or not? But because of politically, but the UK, you talk a lot about the social model and mental distress. You use different words, psychosocial ways of looking at things. Can each of you speak to that? A different way of just saying mental health diagnosis.
Well, the medical model is very individualistic, very liberal. It's about fixing broken things. It's not holistic. Yeah, so you go in, they fix that bit of you, or so they feel, and then they send you back out to the very same society that broke you in the first place. So given what Jackie has already said, that poverty is the biggest cause of mental distress in the first place, what we really need to be doing is fixing poverty. But, we recognize with the social model of disability, the social constructions that are out there around class, around gender, sexuality, around race. These things are powerful instruments that damage people. They cause a huge amount of mental distress. And then when people then go to talk about those things, they're actually told, no, the problem is you. You need to rethink yourself. Take these drugs, as opposed to actually your mental distress is a perfectly normal response to insanity. in society. Yeah.
Yeah.
So we come with that social construction of disability and recognizing how that impacts people, so that we can have some of those discussions, recognize that there needs to be, for example, different forms of peer support to support people, so they're not going in and explaining themselves around, this is what happened to me and this is how I see it, and being told by therapists that they've misunderstood things and perhaps you may be exaggerating. And would you like to explain that a little bit more, because I don't agree with you? So yeah, it's very much about social context, recognizing all of those sorts of issues that people are facing in order to go along that journey with people to be able to provide hope. And it's important that there's diversity in terms of the people who provide that peer support, so that peers can see someone who has hope, has a good job, has all of these things that are meaningful, great relationships with people, because they may well have lost hope about the future. They're living, breathing representation of a possible future.
Yeah.
Karen, do you have anything to say about the two, or Jackie? Yeah.
Go on, Karen.
No, you go ahead, Jackie, go on.
I was just going to say, I was having a conversation with this chap that who's supposed to be interviewing me tomorrow, about how the social model of disability doesn't go far enough. So there's a wonderful guy called David Bolt, who is a blind man, disabled man, who's a professor, and he developed what he calls a tripartite model of disability, and he did it for in relation to literary criticism. But what he said within that theory is about non-normative positivisms. So the positive aspects as a disabled person that are never recognized by non-disabled people. The fact that actually when I have palindromic rheumatism and I'm confined to my bed and I can't move, it makes me slow down. It gives me time to read papers. It gives me a way into things that otherwise I might not have if I'm not a disabled person. And he also talks about the daily effort that he has to exert in order to achieve exactly the same as any able-bodied person would, like in, for instance, getting out of bed and getting into the university. So he reckons that this social model of disability isn't enough, and we need to go even beyond that, in terms of like justice, in terms of recognizing the positives about disability in a way that we currently don't. The work I'm doing at the moment with people with a learning disability looks at emergency care and treatment planning. And under COVID, when people with a learning disability were going into emergency services, they were given what we call a DNR, a do not resuscitate, on their notes, without their permission, without their family's knowledge. And then the reason for that was given as learning disabled. So the very fact that you have a disability or are learning disabled or learning impaired, that clinician thought that was sufficient, that you don't get the same service as other able-bodied people. And you just think, what planet are these people on? Do they live in the same world that I do? So I think we've got a long way to go, even with the social model of disability. I think we need to go beyond it.
Thank you. And here sometimes I think it relates to what we call the social determinants of health. And there have been studies as well of people with mental health issues go to doctors, women will, and they don't even get, or people with other disabilities don't even get checked for breast cancer. So they have to ask for that. So it happens here as well.
Happens
Karen,
here
would you like
too.
to speak to these subjects? Can you add in what you're thinking?
Karen.
She's
I'm sorry, I missed that. I think my connection went a bit strange. I think I do. I'm looking at the time and I'm thinking we could spend the whole day talking about this, because I think we've raised some big topics and we're all good talkers. And I've enjoyed that conversation. I've also been keeping an eye on the chat and seeing that people in the chat are saying that they're enjoying it as well, which has been really lovely to see. So thank you to the people who've commented on it in that way. I guess we should be really polite and let people get a bit of a break before they head off to the next session, because there are so many sessions today. I want to go to all of them, even though it's evening here. I've got a late night ahead of me, I think. But thank you everybody for your engagement with that, and thank you, Anne, for
before they go, it looks like there's some discussion about work with Zimbabwe here. With the
I know
person.
I'm reading it. So Fungai Trevor Mudzingwa. My email address is in the chat. I would heartily welcome you to get in touch.
Don't worry, I've sent you the email and you responded saying thank you. That is the
Wonderful.
contact. So the
Wonderful.
You know, the details are already in your email.
Thank you so much, Fungai, for making that connection with us. We'd be delighted to connect with you. Thank you.
We'd be delighted to connect with anybody, of course, because I think that's I think that's what I've got from the connection with you, Anne, is about making those international connections around. That's peer support, isn't it? And it's just so important. So thank you, everybody, and thank you to Cher for organising this conference.
Yeah, thank you so much.
Really
I mean, I'm looking forward to going to the other ones as well.
Yeah. So which one should I go to next?
And be sure to put your email in the chat if you want. Is that right, Brian? If you want credit for this, be sure to put your email in the chat here at all the participants.
Yeah, we'll send out, if you're interested, a certificate for the presentations that you've attended, and we're saving the chat, so we'll have that. Also, we're going to send out an email to every registrant that's going to have a link to the videos. So all the presentations are being recorded, so you can check them out. Probably won't be till early next week. They'll be edited out, and it'll mainly be the shared screen and who's ever the speaker at the time. So that's the video that's going to happen. And so basically, I'm going to put the schedule back in the chat, so you have that. I'm also Ruth, who is the co-founder of Share. They're doing this conference for free. If you would like, I will put a link to donations. Anything would help out. This is the third annual for this conference, so we've got a lot more momentum. I'm really excited about the presentations. I've enjoyed listening, and so I'm just going to put that in the chat, and I'm also going to share the screen of the next presentation so you get an idea which one you want to go to. Any questions?
Sure. I was just going to say, can you put the donation thing into the emails that you send out to us, so that if we want to, we can do it then, just because I might not find it in among the chat.
Sure, that'd be great. Did you get the email this morning?
We were teaching all day, so I'm not sure.
It went out yesterday. It's just constant contact was a little wonky, so I just kind of like making sure.
I mean, I got one with the program, but whether it was this morning or whenever, I don't know. We've been teaching till about half an hour before we began.
Yes.
Oh, gotcha. Yeah. Well, thank you so much. Thanks. Check out the next presentation. I'm gonna share on the screen. I just put the link to the PDF, which is the whole day. And also, if you scroll down on that document, you can go to just the time slot and read more about the presenters. And there's like a box next to each of the presentations. It'll say like Unity Room or Peace Room. Those are all the Zoom accounts we're using. And you can click directly on that to go into the presentation.
Thank you so much.
Thanks again so much.
Thank you.
Thank you.
Take care.
Thank you. Amazing organisation. Thank you.
Yeah, thanks so much. And lovely to meet you, Anne.
Yes.
Nice to meet you too, Jackie. I think I've seen your emails. So
Good. Yeah. Take care, everyone.
Thanks, everybody.
Thank
and
you.
we want peers across the pond to get more of Karen.
Thanks, Anne.
Thank you.
One more thing real quick. We're going to be, check the website. This is the link. We're also going to be posting everything on there. So let me post that link. It's basically, I'll post the link. That'll just be another way for you to like check for when there's the videos are available on that. Right. Thank you.
Thank you. Hey, Brian, may I be added as a presenter as well? Is that fine for this one? Thank you.
Oh, you're on this one as well?
Yeah, I'd like to be added. Yes, I was at
Yes.
first. Oh, great. Thanks.
Okay, let's see. I'm sorry, for the presentation,
That we just gave. Yeah.
let's see, and for the 10:30 presentation?
No, for the presentation we just gave together.
Right. Okay, let me see. So,
At the 9 a.m. Right.
yeah.
For the future.
Oh, okay, so yeah, can you send us your bio?
I did, but I'll send again. Who should I send it to, Brian?
We have another person that's doing that, so we do have some corrections that go out, and I'll send a link out. But yeah, if you want to email that to me as well, Brian with the Y
To where? Brian, I don't know.
at shareselfhelp.org.
Okay. Sure, we'll do that.
Yeah.
Thank you.
And we'll get it on there. Thank you very much.
I'll get started in just a minute here. I'm going to share my screen. It's not right here. Sayward, can you tell me what you're seeing on my screen?
Yep, the title slide.
Okay, perfect.
Mm-hmm.
If I switch, are you now seeing the co-authors? Okay, perfect.
Great. Mm-hmm.
Wonderful. Thank you all for sitting with me on that technical issue. So we are so excited to be here to chat with you all about this research project that we've been doing, really focusing on self-care and burnout prevention strategies. Specifically, we were working with folks who were peer support workers for substance use disorders, but a lot of these strategies would work for folks kind of across different peer settings. So my name's Sarah Miller. I am a doctoral student in psychology. My research focuses on really thinking about psychosocial supports for folks with vulnerable diseases. So thinking about HIV or opioid use disorders. And I also work clinically with folks with opioid use disorders. I'll let my co-presenters, Maggie and Sayward Harrison, introduce themselves as well. Maggie, do you want to go first?
Sure. Hi, I'm Maggie. I'm a third year, well, finishing up my third year in my doctoral program here at University of South Carolina. My research interests focus a lot on like youth-led efforts to address mental health stigma and prevention. However, clinically, I do work with a lot of folks with substance use disorders. So excited to be here today.
Yeah. And same for me. Hi, everyone. My name is Dr. Sayward Harrison. I'm an assistant professor at the University of South Carolina in the Department of Psychology. I'm a health psychologist, and I really focus on how we can better support people who are living with stigma healthcare conditions. So most of my work is in the area of HIV interventions, both prevention, treatment, peer support workers have been critical in our efforts to improve outcomes for people living with HIV here in the US and across the globe. And more recently, I've shifted into doing more work around the opioid epidemic here in the US. And that's going to be the root of what we're about today. So it's great to be here. Thank you.
Before we get started, we just want to acknowledge our co-authors who are fellow students with us at the University of South Carolina, Ellie Liu, Sarah Grace Ferry, Elizabeth Podolsky, and Wendy Chu. And they all contributed significantly to this research, but were unable to come today due to some schedule conflicts. We don't have any conflicts of interest to disclose today. Just to give you a little bit of an agenda for where we're going to go today. First, we're going to tell you a little bit more about our current work and how we got into this field, a little bit about a center that we just started focusing on substance use. We'll give you some background on substance use disorders and kind of how we got to the current study. And then we're going to spend the bulk of our time really digging into self-care and burnout prevention strategies, hopefully for you to be able to take some of those home with you and use them. And then we're going to save some time for question and answers at the end. But feel free as we're talking to pop questions into the chat box as well. Before we get started, we do want to get a sense of the room. So if you can put in the chat box what your current role is, so whether you're a peer or a researcher or an organizer, what general populations you're working with, and then just, what brought you to this session today? What is your goals? What do you want to get out of this session? And we'll give you a minute to type that up and put it in the chat box so we can get a sense of what everyone is coming to with today. just realized I can't actually see the chat box. But that is okay.
We've got people commenting, working for different CRSS programs, working in a CRE, running peer training programs out in the community, some people who are involved in work through CC. So lots of exciting, a behavioral health specialist, lots of kindred spirits with us today.
Yeah. Well, that's great. So excited for all of you to be here. So with that background, I'm going to turn things over to Sayward to talk a little bit about our school.
Sure. So at the University of South Carolina, we have been really fortunate to recently receive a training grant from HRSA, Health Resources and Services Administration. So I wanted to share a little bit about the background and how we're moving into this work. So recently, HRSA has identified that we're facing a critical shortage nationwide in terms of the numbers of psychologists, mental health professionals who are receiving training to be able to come out and go into the field and work in substance use disorder prevention and treatment. So I'm going to talk in a few minutes about the history of the opioid epidemic here in the US, but probably each of you are really familiar with this idea that we're really in a crisis around opioid dependence, opioid misuse, opioid use disorder here in the US. Opioid epidemic has shifted over time, but is really impacting every community. And probably if I asked for the people who are on this call today, every one of us could say someone we've been impacted by an overdose death or by just more broadly a substance use disorder, whether that's you, someone in your family, someone who you work with, a community member, who you've seen go through this struggle, dependence. So HRSA has identified that in order for us to really address this as a country, we need more mental health professionals to come out of their training program ready and able to partner in efforts to respond to the opioid crisis. So we received funds to start a training center at USC called the Supporting Substance Use Disorder Services in South Carolina Center. I'm the director of the center and have some fantastic other faculty who are involved. And you can turn the slide, Sarah. And the long goal of our is to really address this critical shortage of there not being enough psychologists who are currently working in substance use disorder prevention and treatment. And to also think about how we can improve our statewide outcomes here in South Carolina related to opioid dependence and other substance use disorders. So the goal of our new center here is to provide high quality training for our doctoral psychology students so they can both get the knowledge, but also those practical clinical skills so that they can partner with other people, including peer support specialists, in addressing opioid dependence in our communities. Our goals are also to just increase the number of PhD level psychologists. So here in South Carolina, we experience tremendous shortages of really all healthcare and mental health professionals. Out of all 50 states, we're 50th in the country for the number of psychologists per resident. So we're dead last. We have very, very few psychologists, only one APA accredited training program in the whole state, and that's ours. So we really realized that we were not doing enough to equip our students to engage in prevention and treatment of substance use disorder, including opioid use disorder. And now we're really intensifying our efforts to build up more transdisciplinary research, to contribute to improve our policies statewide too, of responding to the opioid crisis. So we've developed a fellowship, and our fellows are actually the ones who this research project that we're going to talk about today. But we've developed a fellowship here at USC where we give our doctoral trainees in psychology didactic training. They're taking coursework in responding to the opioid epidemic and evidence-based prevention and treatment strategies. And then they're also placed out into clinical externships in community-based settings, in hospital settings, and primary care settings, where they're doing hands-on work in integrated care for individuals with opioid use disorder and other substance use disorders. All right, so I wanted to just talk for a minute about the current state of the U.S. opioid crisis. So, so we know that opioids they've been around, and humans have been engaging with them for as long as humans have been around. Our bodies are built with receptors that were to opioids, and opioids are naturally occurring in our environment through the poppy seed. So you can think about, historically, you might have heard about opium dens, or seen people smoking, or learned about how people used to inject morphine. All of those are different historical ways that humans were consuming opioids. What's happened recently is that shifts in the formulation of those opioids, and then more widespread access, has really created a crisis here in the U.S. So this current crisis can be dated back to the 90s. I don't know if people have read or watched Dope Sick. There's a number of fantastic books out there. The least of these, Dreamland, that detail these different stages of the U.S. opioid epidemic, and a number of them are now being turned into really compelling programs on Netflix, on Hulu. So I would recommend watching these to get a good sense of the background of this crisis we're in. But from the mid-90s to the mid, like 2014, there was a lot of overprescription of OxyContin by healthcare providers here in the US. And this was really driven by a very kind of systemic issues in our healthcare system. There was new medicines that were available that did a really effective job reducing people's pain. So people who were in pain wanted them, it made them feel better. Doctors and other prescribers were being encouraged to get those pain levels down. Pain was added as what's called the fifth vital sign, where every time you went into the doctor's office, now suddenly you were being asked, do you feel any pain? Oh, we've got something that can help reduce that pain. So in this very short period of time, OxyContin began to be widely prescribed, which created base in our country ever of opioid dependent individuals, because what we know about opioids are they're highly dependent because they're so good at producing things of euphoria and pain relief in humans. In the second this crisis, we began as a healthcare system to pull back on that overprescription, but people were still really dependent. So as suddenly it became more and more difficult to get OxyContin and more expensive to get those prescriptions filled, many people who were now dependent on these medicines began turning to opioids that they could get off of the street, often more easily and more cheaply than going in and getting prescriptions for them. So in the early 2000s to around 2017, suddenly now there was a shift to using heroin, right? A shift for people who were dependent on OxyContin to shifting to heroin use. And at this time, that the supply of opioids in the US really shifted from healthcare providers to Mexican trafficking groups who were bringing heroin over the border and then delivering it to individuals in the US who were dependent. So we saw heroin-related emergency room visits skyrocket, overdoses began to increase, and the opium poppy agriculture was really what was driving that. But we're now in a whole new where suddenly there were advances in how people could produce synthetic opioids, so often relying on bringing in chemicals from and kind of backroom production through pill presses and counterfeit pill manufacturing. Now we've seen that what people are consuming for opioids is typically fentanyl. So heroin has dropped steadily and been replaced by fentanyl use in the US. And this is creating a real crisis. You continue. So what we know is that nationally, when we look at drug-involved overdose deaths, we've seen an absolute skyrocket over these years. In phase 1, there were overdose deaths from prescription opioids, and you can see on that grayish line, these really kind of steadily rose over time. Sarah, you can go to the next slide. Then in phase 2, where we see this shift to heroin, that's that black line, we see increase in heroin-involved deaths. And then now in phase 3, we see just an almost vertical line of fentanyl-involved overdose deaths. And these are what we call these synthetic or these human-produced opioids that we have. When we think about fentanyl, so South Carolina, fentanyl is now involved in about 4 out of 5 overdose-related deaths. Fentanyl-involved overdose deaths have increased over 400% in our state in these last few years. And what happens is that fentanyl is just much, much, much more potent than heroin. So individuals who maybe used to use heroin and are now consuming counterfeit pills, that the amount that they're getting is just massively increases their dependence on that substance and creates a real risk for overdose deaths. So fentanyl is 50 times more potent than heroin. And again, it's just rapidly replaced all the other opioid drugs in our US supply. And you can go forward now, Sarah. So when we think about dependence, whether it's on opioids or on alcohol or a different drug, when we're thinking about substance use disorder, we're really focusing on 4 key criteria. Impaired control, that individuals begin needing to use the substance more often, longer periods of time, and they're not able to control their use as they once were. Therefore, they're spending much more of their time seeking out that substance, consuming that substance, and recovering from those bouts of use. So it's beginning to eat up lots and lots more of their time. So this links to that social impairment, because so much of one's time is now spent consuming, using, and recovering from this substance. A person begins to have difficulty fulfilling other roles in their life, whether it's fulfilling their roles within their family, within their relationships, at school, at their work. We also see risky use, right? So an individual may be continuing to use even though there are risks to their health, risks to their mental health, risks to their relationship. They might be seeking that drug and using that drug in hazardous environments, but that dependence, that physical dependence is so strong that they're not able to stop or resist, even though they may recognize and be well aware of this risk. And then we're going to talk too about pharmacological criteria. Thank you, Sarah. Which is really that the body is changing in the response to the substance use. So when we think about diagnosing substance use disorder, the recommendation is to use the Diagnostic and Statistical Manual of Mental Disorders, or the DSM-5. And this is used to diagnose substance use disorder across a spectrum. So depending on the number of symptoms an individual exhibits, they may have mild, moderate, or severe substance use disorder. And it's really important to know that substance use disorder and other mental health disorders often co-occur. It's really common for individuals who are experiencing, whether it's depression, anxiety, post-traumatic stress disorder, or other mental health disorders, to have a co-occurring substance use problem. So it's important for individuals to both receive assessment for substance use disorder as well as any other potential mental health disorder. You can turn it, Sarah. Thank you. And so here we just see, what it looks like when we look into the DSM and what some of those symptoms are. So when we think about substance use disorder, again, we've got that first impaired control over substances, consuming in larger amounts and for longer time. An individual might feel like and know they need to cut back, but they're not able to regulate their use. They might have had many attempts to cut back, but those are not successful. And really, we think about that craving, that drive, that again leads to those sermons that I discussed, those risky use experiences. Now, I wanted to spend a moment or two talking about pharmacologic criteria. So when we think about, substance use disorder, it's really important to understand addiction, or we could also say dependence, as being a chronic disease in which areas of our brain that are responsible for our reward systems, for our motion, even for memory, they become changed and they become dysfunctional, right? So brain impairment is really what underlies substance use disorder or dependence on these different substances. And we see that because we see these pharmacologic changes. So tolerance. So individuals with substance use disorder begin to need higher and higher doses of that substance to achieve that same high feeling, that same, whether it's euphoria or that same reduction of pain that they initially achieved, which with much amounts of that substance. So we see a physiological dependence grow within the brain of an individual. We see symptoms of withdrawal. So if an individual is not consuming that substance, they begin to show signs and symptoms because blood and tissue levels of that substance decrease, and the body doesn't like it. Now the body has developed this real need to keep levels. So when they're not there, an individual experiences what we call, dope sickness, really, really strong, terrible physical symptoms that make them just feel yucky. And again, kind of serve to reinforce that use, because then when they use again, those terrible symptoms go away. And that's why it's also so important to understand what our current treatments are. Use disorder, in particular, opioid use disorder. So our gold standard for opioid dependence is medication-assisted treatment. So when an individual is able to receive a medication that can help reduce those cravings and help blunt that high that those opioids would typically give. So those medications in the US that are available include ones you might have heard of before, like methadone, buprenorphine, Suboxone, and naltrexone. And what these medications do is they normalize the person's brain chemistry who has become so dependent on opioids. They help reduce the cravings for those opioids, and they normalize the body's function so that the person doesn't have to go through those painful opioid withdrawal symptoms as they slowly wean off of their dependence. These also help for individuals who are dependent or addicted to opioids by blocking the euphoric effects, right? So beginning to kind of break that, that association between the drugs and that high, good feeling for the individual. So these are really life-saving tools. So individuals who are misusing opioids, who are dependent on opioids, really need to get in to see a healthcare provider who can, with medication treatment. Okay, so now that we've talked a little bit about the background of the opioid crisis in the US, we're going to shift and talk about a new project where our fellows have been working with peer support workers.
Thanks, Sayward. So I'm not going to talk too much about peer support workers since some of y'all are probably familiar with it. But we just wanted to highlight kind of like the central and key role to recovery, right? So peer support workers fill in a lot of gaps, providing necessary resources to individuals who are entering recovery or in recovery, and fill some needs that clinicians often cannot provide. So that extra social support, shared lived experiences, and peer support workers have often been associated with better outcomes for folks in recovery. Next slide, Sarah. So a little bit of background about our study. Just briefly, I want to highlight kind of what inspired us to really engage with peer support workers is, so through our fellowship, we had the privilege of going up to Greenville, which has our kind of big healthcare system here is Prisma. They have a very big substance use disorder center up there. We got to meet some folks, see the work they were doing with capacity building and just the overall structure that they had. And we got to meet some peer support workers who were working in their system. And we were just very struck and inspired by the way these folks were describing their experiences, working with their participants and clients, having that lived experience, filling those gaps. And we really thought about is, what does support look like for peer support workers when you have those lived experiences and you're working with folks in your community? What does support, self-care, and mental health look like for a peer support worker? So really our aims were to just broadly understand the experiences of peer support workers for substance use disorder specifically. We realized there's not a lot of research out there right now that touches on peer support workers and how that impacts their mental health. And then we really wanted to identify burnout prevention and self-care strategies that are used by peer support workers, and then identify additional ways that organizations can better support burnout and self-care for their peer support workers. And then so for this portion of the project, we're just going to be focusing on those burnout prevention self-care strategies. This was a very big mixed method study that we did. We sent out surveys, asked many questions, but for the purpose of this, we really wanted to focus on burnout prevention. And our main goal today is for you to walk away with some tangible ideas on how you can engage in self-care or potential ways that you can support peer support workers at your own work. So for a specific study, we interviewed and sent surveys to 25 peer support workers for substance use disorders in South Carolina. They all had been peer support workers for at least 3 months. Our interview guide, we had a cool opportunity to kind of involve a peer support specialist. So they got to provide feedback on our questions, ensure that what we were asking was kind of representative of peer support workers' experiences. Then, of course, we transcribed our interviews, and we were trained in rapid qualitative analysis, which is kind of like a quick way of scanning our transcripts for common themes and pulling those out to really make some of the quotes that we're going to talk about later. So just a little bit of background as our participants. As I mentioned, all of our participants were peer support workers who were in the job for at least 3 months. We had a wide array of identities, so pretty diverse with gender, mainly white participants, and then a wide array of levels of education, and then full-time, part-time employees, as well as volunteer peer support workers. A little bit more about our participants. So our average age was around 49 years old. Thinking about how many years they were in recovery, average was around 3 years working in peer support. So we had a wide range of how long folks have been working in their role, and our average was around 12 years. A big key piece here, as I'm sure some of you peer support workers know, is the hours of training, which is something we're interested in. Of course, there's a lot of training, continuing education, but our average here for our participants was about 112 hours of training. And then just to think about how many folks they're serving in their role within the past month and lifetime, we can see in the past month, our participants were interacting with, on average, 38 people in their community. And then over a course of their lifetime, over 841 as an average of folks they're interacting with.
All right, so we're going to shift gears to thinking about some of these specific self-care strategies that folks were using. But before we do that, I want to frame our conversation as to why self-care is really considered to be important. So go ahead and jot down some ideas of why you think self-care might be important. Why are you here? And Sayward, I'll have you kind of shout out some of the main findings that you're seeing in the chat box as folks are putting them in.
Sure. Okay, well, I put the first one in. So to help prevent burnout, especially when you're in this really high stress role. Any other ideas about why self-care is really needed, or why it's something that we should focus more on for peer support workers? I can speak a little bit from my past role as a practicing psychologist, that again, these are really high stress positions. When you're caring for other people all the time, I think it can be easy to forget to care for yourself, and then your own mental health or physical health suffers.
Absolutely. And some of our participants in our study kind of touched on this with some analogies that I found really helpful. And you'll see on these slides, there are names. These names have been de-identified. So they're not folks' actual names, but we found it helpful to kind of identify who they are. So one person said, if you water the root of the tree, the whole tree is taken care of. But if you forget the root and care only for the branches, you can't keep the tree alive, right? So burnout, if I'm trying to take care of the patients and I'm not taking care of me, it's all going to fall apart. Another person talked about keeping their cup full to take care of others' cups. And then one other individual shared a quote that I found really insightful of, you could work 24/7 trying to help people and not make a dent, in the problem. So you really do have to set boundaries and do that self-care for yourself, or you could burn out very easily. So, in order to have longevity in the field, you really do have to take care of yourself every day. And I think these really just highlight the importance of making sure that we're taking care of ourselves, not only for ourselves, but also, for those folks that we're serving, so that we're able to keep going.
Yeah, and I'll just add in, Sarah, from the chat. Thanks so much to people who are participating on the chat too. So, people have said, it just is really necessary to maintain our own stability in these roles, to manage the stress, to help us do the best we can do, giving our services to others. And also, I loved this one, to continue to heal. So especially as in our work with peer support workers who are working in substance use disorder prevention. So these are recovery coaches who are in recovery themselves. That what you just shared there in the chat, I think McCormick, is really powerful. We're also often healing from our own past traumas or experiences while trying to do this role and help others, which makes self-care just critical. Thanks.
Thank you all for participating and for sharing your thoughts. So we're going to talk through some of the specific burnout prevention and self-care strategies that folks were using, who we talked with. And just to kind of frame this conversation, we're going to be going through a lot of different self-care strategies. And hopefully some of these will be useful for you, but I think it's the key thing that we saw through the interviews was everyone had different strategies that worked for them. And so we wouldn't expect any individual person to engage in all of these strategies, but really to pick the ones that work for you. And we'll walk through each of those. So the first main theme that we saw was kind of setting up work-related self-care. And the first thing that participants really talked about was boundaries that they set with work. And pretty much everyone in our study really identified having good boundaries between work and home life was really important for maintaining their own mental health, their own recovery, as well as preventing burnout. But how people did that did change based on the individual. So there's 3 quotes on the screen. One individual talked about how, he told his clients they could call him 24/7. But that doesn't mean he answers his phone 24/7. And so he said, you can call, but if my phone's off, I'll call you back. And that was his way of being a resource to folks, and letting them know they can call him, but making sure to be able to have time that, he was off the clock. Another person, Todd, talked about how when he had seen his friends hit points of burnout, them saying, I don't have bandwidth for this anymore. Someone else needs to work on this. Someone else, Tinkerbell, talked about how her boss was always working in the evenings and sending her emails in the evenings. But she said, nope, at 5 o'clock, I'm done. I'm not going to check the email. I'm not going to respond to that email after those hours. Other folks talked about how important it was for them to clock in and clock out at the right times, or having other types of boundaries where they said, this is my hard line. That's not what I'm going to cross. And these were different for different folks, but the common theme was having those boundaries that they established. We also found folks talking about kind of really thinking about their mindset when it comes to their work. A lot of folks talked about how it can be really difficult to be pouring into individuals who, are not in recovery yet and helping them to get to recovery. And they talked about how they really needed to kind of have some distance of that. So recognizing what their role was, that, they can't save every person, and that it really is up to the individual whether they enter into recovery or not. So folks shared about how, they couldn't want other people's recovery more than they did. Another individual talked about how she reminded herself, at the end of the day, I'm getting my paycheck, whether or not folks are sober or not. And I think all of these really go to highlight the impact that this kind of mindset shift can have, of thinking about what is my actual role and not holding myself accountable for things that are beyond my control. Other things that folks really talked about was taking time away. So this encompassed lots of different areas, from I'm going to take time off, go on a vacation, go to the beach, go to the mountains, have time that's my time to relax, to even little things like I'm going to take 10 minutes in the middle of my day to take care of me and respond to texts that I get, or to really unplug from everything in the midst of my day and take that time off. A really important theme that we saw in terms of what people shared was thinking about mental health days and destigmatizing those, recognizing that, mental health day is a sick day, and it's something that is really needed for these individuals. And they really focused on that. And so really what we were seeing here is the importance of, having that time off, whatever that looks like, whatever is restorative for you, but recognizing that work was better after having that time off. Another work-related self-care that folks talked about was how supportive supervision was for them. So people really identified a burnout prevention strategy was having a supervisor who is qualified and could speak to the clinical aspects of things. And then having supervision regularly when it's going to come up, so that you can have those questions answered, you can get those supports, especially with those tricky cases that some folks have. Others also mentioned, the value of having peers that they could go to. So other peer support specialists that they could talk with about their work, and who also have that shared experience of being in recovery and helping others in recovery, and the importance of that. We also saw some self-care strategies related to recovery. So for these peer support specialists, all of them are in recovery themselves. And so a big way that they were taking care of themselves was to take care of their own recovery. For a lot of them, that meant going to self-help meetings, so 12-step meetings, AA, NA, or even just reaching out to other peers in recovery to make sure that they were getting the resources that they needed. And a lot of them also talked about how valuable it was that resources were available both virtually and in person, so that they had that flexibility. The next theme that we really saw was thinking about one's physical health. And this really spans across lots of different avenues. So it came from exercising and valuing your physical body, to eating the right foods, sleeping well, visiting the doctor, taking medications that you're supposed to take, but then also things like pampering yourself. So people talked about going to the spa, getting a massage, having supplies for a bubble bath at home after a stressful day, getting your nails done, making sure to go to that hair appointment, and taking care of all those physical aspects of yourself that help you to feel better about yourself. And then we also saw people talking about really their mental health and the importance of taking care of themselves. A key theme that people mentioned was mindfulness. So a lot of them talked about using mindfulness apps on their phone that they found, where they would play a recording and listen to the mindfulness. Others just talked about meditating in their day. One individual talked about how he adapted meditation to really fit with his schedule. So he had a long commute to work, and he said that's That's my time to meditate. I take that half hour to meditate and take care of myself. A lot of other folks talked about having their own therapist and how crucial that was for them to be taking care of themselves by, as Sayward mentioned earlier, like dealing with their own trauma and taking care of their own mental health being really important, especially given the difficult work that they were engaging in. And another key theme that folks mentioned was seeing a psychiatrist, taking their antidepressant or other mental health medications as really crucial for supporting their work as peer support workers.
Thanks, Sarah. So next I want to highlight family, which was something that was talked about a lot as a huge role in self-care for peer support workers. Specifically here, folks talked about engaging in fun activities with their kids, like attending lacrosse games, playing with their kids, hide and seek, just having these little fun and casual activities with family members, like their own children, siblings, and spouses, was something many peer support workers talked about as being restorative and really supported their mental health. Next is hobbies. So again, many of our peer support workers talked about hobbies, so interests that they loved and just connected with. Obviously, they differed from person to person, but there were so many interests that ranged from cooking to puzzles, sports, even just cleaning the house, crafts. One of our participants, Lauren here, talked about that, making sure that she has a hobby as something else to do. It's something just to soak up and find positive outlets outside of work. So hobbies is something many of our peer support workers mentioned engaging in for self-care. Next is spirituality. So a couple of our peer support workers mentioned this role of spirituality as a very important way of coping, avoiding burnout, connecting with kind of this higher being and role for their life. So whether folks went to church, just thinking about faith. Tinkerbell here highlights that they're not typically a person that goes to church, but the first thing they do when they wake up in the morning is read through meditations, connect to this higher universe and this higher power, really just to center and ground themselves. And Lauren also mentions that here. I'm sure some of y'all are potentially familiar with compassion fatigue, but just the potential negative impacts of the trauma you might witness and the work that you're doing, being able to connect with faith was something that was grounding for our peer support workers. And then finally, we want to switch some gears and talk about specific workplace support. So a lot of our peer support workers identified the really great things that their organizations and agencies are doing to support them in their role. And some of these could potentially be used to think about, generally, how can we support peer workers in their efforts to engage in self-care and avoid burnout, whether in the workplace, but also outside of the workplace. We have some quotes here where Todd talks about the clinical world, sometimes not being able to have a voice, to be able to voice the actual core value of a peer worker holds, and really experience. So he saw peers getting substituted for other areas of work. Usually they're more than their menial job, so maybe having to take on extra roles. Educating from the top at each, because oftentimes maybe folks who are higher up, like in administrative roles, don't actually know what peer support workers are intended for and are not really clear what the role is there. Next, we have April, who talked about believing that substance use peers and mental health peers, there ought to be a pay parity. So of course, some organizations offered health insurance, but April wanted to talk about, Medicaid, manual goes, talked about billable pieces, but there was this notion of parity for pay that was critical in thinking about ways to support their self-care. One of our participants, Pouch, talked a lot about directors and supervisors at work, and just their overall attitude, work ethic, and relationship that they had. And this was a quite positive note here that Pouch was touching on directors kind of fussing at them when they're working too much or working overtime, and not really making comments that they're not working enough, right? So really focusing on having that balance between how many hours are you working, and really just working with Pouch to make sure that his role was realistic and he had the capacity to complete his responsibilities. So just a final note about workplace support is really just for admin and at that organization level, really thinking about different policies and procedures that could potentially be in place to protect peer support workers and their time and ensure that they're fulfilling the role that they were, hired for. And then finally, we want to touch on individualizing self-care, and Sarah mentioned this before, but of course, self-care looks different for different folks. And a lot of our peer support workers comment on this. So Cassidy here, talks about that self-care is not just essentially there's no one definition of self-care for folks. It looks different for people and their needs and the different roles that they're thinking of. It's kind of a big take-home message that we're hoping to center here is we've got a lot of self-care strategies with so many different domains, from family to work-related self-care, hobbies. And of course, each one may work for some and may not work for others. And it's really important for us, and especially peer support workers, to think about developing a way that fits best for them and taking care of themselves, whatever that looks like.
So I think, thinking about all of those amazing quotes from our peer support workers who took part in this study, to sum up, certainly those findings speak to the fact that peer support workers fill really unique roles that can be highly stressful, that sometimes there's a lack of clarity from others about what their particular role and their training and their deep expertise is, and that can play a part in their own experience and their own stress level and the burdens of being in this position. We heard from our participants that attending to those self-care needs is critical to reduce burnout, to reduce their to help make sure that they're able to provide those services to their own clients and make sure that service delivery remains, high quality. And for us, the next steps for us are really thinking about how we as psychologists and future psychologists can help play a part in supporting those unique needs that are experienced by the peer support workforce. So, as you probably, when you think about psychologists, you think about maybe individual and group therapy. And those are certainly things that stand out to me as a role that we as psychologists can meeting needs within the workforce. And we heard many of our participants, talk about the importance of attending to their own mental health needs, whether that's prevention or whether that's treatment focused. We also saw other opportunities for psychologists to become engaged in this work. So we do a lot of work within our department around mindfulness and meditation practices. Those would be potential areas that we're interested in partnering with organizations to see, can we deliver these types of services to your peer support workers? We're trained in different relaxation methods, such as deep breathing, diaphragmatic breathing, other strategies that can help us to really, relax our mind and relax our physical body as well. And then finally, psychologists, maybe you don't think about it as much, but psychologists, especially within our department, which has a clinical community focus, get a lot of training on how we can go in and serve as consultants to organizations or to healthcare and hospital systems to help figure out how can you do a better job supporting those needs for these critical staff members. So another area that we're thinking about in terms of the training of our students is how can we make sure that they're trained to be able to provide that consultation. So as we heard from our peer support workers in this project, the systems, the supports that are available at their workplace, what's being provided to them in supervision, how their boss is treating them and supporting their own mental health needs are really, really important for maintaining good mental health for our workforce. And I think Sarah's going to wrap us up with one final activity.
So as we spent a lot of time today talking about all these different self-care strategies. And I know for myself, when I hear all of these things kind of stated out loud, it can be overwhelming. And sometimes I'll feel like I need to do everything at once. But we thought it would be useful to just take a minute to think about, what's one self-care strategy that you can do for yourself today? Right? It doesn't have to be something that you're doing every day, but what's one thing that you can do today to take care of yourself? And go ahead and put those in the chat box. And I'd love to hear all the ideas that folks come up with.
Okay, I can read out some of these. Oh, I love some of these strategies. So we've got someone who's going to treat themselves to a pedicure. I loved those comments from our participants about just the need to pamper yourself, right? To take care of yourself, given all this surrender. Someone's going to go outside on this cloudy day and do some grounding exercises. I love that. If you all are not familiar with grounding exercises, just do a quick Google and really helpful and easy to learn how to do. Working on remaining calm. Someone mentioned doing a body scanning practice, really checking in with the different areas of your body to identify areas where you might be holding on to that tension. Going outside and getting some vitamin D. Going to be able to see the northern lights in the sky. So having those moments to connect with nature, amazing. Massage, taking the stairs, staying moving, staying active, chair yoga. I mentioned I'm going to finally download Headspace, which a number of people have recommended to me because they've got some great meditation and mindfulness, quick activities on that app. Taking time to connect with a friend. So I love to hear it. And now it's just us holding ourselves accountable and making sure that we take the time, because we're worth it, to go out there and do those things that we've just identified. So amazing. Great work, everybody.
So excited for us all to engage in those. On the screen is Dr. Harrison's contact information if you'd like to collaborate with us or have any further questions. But at this point, we'd love to open it up with our last remaining minutes to kind of hear from all of you if you have questions or other strategies you use to engage in self-care that you'd like to share with others.
Yeah, or if there were any surprising findings or anything you've heard about that's really effective and helpful that we didn't mention, that might be something for us to consider.
I just have a quick question. I know that you mentioned in the beginning that you guys are like, I think you said the 50th state or 51st state that you guys don't have a lot of mental health.
Yeah.
Basically. Sorry, you can correct me if I'm wrong, but it was along those lines. And I just wanted to know if there's anything that you guys are doing to kind of like revamp that in your state in South Carolina.
Yeah, it's a great question. So I think, one part of that is just trying to figure out how to make mental health services more easily available, since there is such a lack of them in our communities. And, I'll say that we have developed over time a psychological services center where Maggie and Sarah work. And so we place our students in that center, and they can offer either free or very low cost services to our community. It's a great way that we can help to meet some of those unmet needs, as well as get our students just excellent training opportunities. So we have developed this large, our PSC, we call it, which is kind of our clinic. And I think more broadly, we're very interested in looking at training more master's level clinicians. I'd say historically in psychology, our association APA only accredits at the PhD level. And I think that's a real problem, because that just means that we don't have this many people who are training at the master's level and then going out in the community to provide mental health care. So we are in talks. APA is actually going to change that over these next couple of years and begin accrediting at the master's level. So I think broadly, like nationwide, that's going to be really important to just increase of mental health providers that are out there. And I don't know if Sarah or Maggie have other thoughts about other ways you've seen us trying to meet those needs here in South Carolina. Cassidy, I see you raising your hand.
Yes, I had a question. In the presentation, you mentioned how it's important to have a supervisor. What would you recommend for our leadership team, right, that don't really have a supervisor? They are the supervisor. Have you worked in that? What have you seen?
Yeah, that's a great question. So one of our participants actually talked about this, where she was a supervisor and was like, I'm at the top. Who do I go to? And some strategies that she used is reaching out to supervisors at other organizations kind of across the state, and asking them for consultation, right? So when she hit a point where she didn't know what to do, like to ask for a consultation. Another really cool thing that exists in our state, that I think if it doesn't exist where you are, it would be awesome to create, is we have a group called Peers for Peers, which is a group that meets virtually every Friday night, and they're all peer support specialists. And it's a support group for them. And so they'll have different speakers come in on different topics. But then other times they just have case discussions, where, someone shares, this is what's going on. I want to hear your thoughts. And a lot of folks who, kind of were at that upper level, they were supervisors, found that really helpful, as well as in South Carolina, we're a pretty rural state. And so there's some folks who they were the only peer support really working for their organization. And so they found that helpful to be able to get that connection with other peer supports when they didn't have necessarily that supervision available to them internally within their organization. Did that answer your question?
Yes, thank you.
Great questions. Well, we thank you all so much for your attention and for participating with us today. Please follow up if you have any questions or ideas for future collaborations with us. We'd love to join together. All right. Have a great day.
Sorry, can I just ask a practical question? I'm sort of jumping in and out of sessions, and I'm in Australia, so I don't know what the time is. What time is the next session?
Hi, my name is Brian. I work for Share. Next session is at 12:30. So this is sort of could be lunch break. I'm going to share on the screen the schedule, so it'll be up here. Right. So if anyone pops in the room, they'll be able to see it. And then also in the chat, I'm going to post the link to the PDF that everyone's using, just so you have it on hand.
Thanks very much.
Also, they just wanted me to let people know that they're this is a free conference. They are accepting donations if that's possible. I'm just going to put the link in there and see if you're interested. We are going to have all the videos available probably next week. I'll also post the chat for that. In the chat, the link for that. It's basically how you got here. And then we're going to send out to all the registrants an email that'll have all that information, the links. If you have presentation information you'd like to share, email it to me, Brian, with a Y, at Share, and we'll keep in contact there. Thanks. I've enjoyed listening, definitely. So if you have any questions, hit me up in the chat and I will post that stuff, and I'm going to share the screen of the schedule. And thank you for presenting. I didn't get on here to kind of say things, but you guys took off and it's awesome. Thanks. Pros.
Thanks all. Bye.
Bye-bye.
Actually, sorry, just more clarification. So what's the time now?
Right now it is 11:29. So the next presentation will be in an hour, starting for other rooms, or maybe some other rooms right now continuing. But the next
Okay.
one, this room is 12:30, and everywhere else. That's the next one starting. So an hour.
Okay, so that's 5:30 for me in an and it's the 12:30 session. Thank you.
You're welcome.
Hello, is anyone present?
Hello. Yeah, I'm here.
Oh, okay. I'm calling in on a phone call, so I can't see the screen.
Okay.
Is the meeting delayed?
The meeting that we just had is finished. This is kind of a lunch break. So the next one starts at 12:30 in 45 minutes, 43 minutes.
Oh, okay. Thank you very much. I appreciate it.
Sure, no problem. Do you have the schedule of the entire conference?
I do. I just misread the clock.
Okay, just want to make sure you have the Zoom links.
Yes, I'll call back in at 12:30.
Okay, great. Take care. Thanks. Hey there, this is Brian. I just made all 5 of the presenters co-hosts. Is there anything that I can do to help? I'm going to be moderating, handling out any kind of tech support issues or anything like that. Is there anything I can help you with in advance?
I think we may be good. You'll be doing introductions, we understand?
Yes. Would you like me? I see, I'm sharing the screen right now. Would you like me to read the complete bio?
However you've been doing it. And
Okay. If it's easier for you to, just basically give your background, if that's easier, it's fine doing that way. It doesn't really necessarily matter. Even though we're recording the entire session, when I edit it, it'll just be from the beginning of your presentation. And then all the information will be also included in the one that's posted on YouTube and on our website. So I'm going to wait about 2-3 more minutes and then we'll get started and I'll do instructions. Thank you. I just saw in the chat that someone doesn't have audio. Can you hear me now? If not, can you check your settings? Make sure that you have your audio set to your either computer device or any other speaker that you may be using. If you're not hearing audio as I'm speaking now, there's just nothing going on unless I'm speaking. We're going to be starting in just a moment. So get me back in the chat if you are having an issue still. Let's see. Welcome, everybody. This is the Peer Workforce Conference, Bridging Research and Practice. My name is Brian. I work for Share. We are going to get started with this next presentation, 12:30. It's just started now. So the presentation title is No, Nothing, None. Answers to 3 critical questions about supervision of peer support workers. Our panelists are Amy B. Splagnolo. I'm not sure if I've been right. She's a doctor, associate professor at Rutgers University. Amy's experience includes over 20 years of curriculum design, staff training and consultation for the behavioral health sector. She also brings a decade-long commitment to training and educating the peer support provider workforce. Currently, in her role as program director for the Academy of Peer Services for the New York Peer Specialist Certification, she oversees the development and quality improvement process for over 90 online courses for the certification of peer specialist in New York. It is the only platform of its kind in the world. Amy has provided remote and in-person supervision for nearly 10 years and trains organizations on the use of supervision strategies. We also have Joanne Forbes, PhD at Rutgers University, Baltic Street AEH Incorporated. Consults nationally on system transformation and peer support service delivery, training, and supervision. In addition, we have Rita Cronice. I'm not sure if I'm saying it right. Please correct me when you jump on. Thank you. Distant faculty, Rutgers University Department of Psychiatric Rehabilitation and Counseling Professions, and co-director of the Peer Support Services Technical Assistance Center, Peer TAC, and coordinator for the Academy of Peer Services Virtual Learning Community. We also have Jonathan P. Edwards, PhD, LCSW, ACSW, NYCPS, and adjunct professor at Columbia University School of Social Work. Dr. Edwards' research focuses on job satisfaction, supervision, peer support work implementation, and organizational change. And our final panelist is Geeta Enders, LMSW, MA, CPRP, NYCPS, Director of Peer Services, New York City Health and Hospitals. Geeta oversees numerous healthcare delivery systems, activities, and concerns impacting individuals who use mental health, substance use, and co-occurring treatment services. She spearheaded the development of and provides oversight to the New York H&H Peer Academy. Prior to joining NYC H&H, Geeta provided services ranging from board membership to directing training at peer-run agencies in Arizona. She presents locally and nationally on programming and supervision. My name's Brian again. If you have any tech issues, please send me a chat. Try and send it to me directly if it's some sort of tech issue. I'm going to go ahead and turn it over to our presenters. So we welcome them, and we're very excited about this panel. At the end of this presentation, I'm going to post again the conference directory, just so you have it on hand. Also, if possible, if we are accepting donations, this conference is free and it is running by share. So if you'd like to help so that we can do these conferences more often. And also, if you'd like a certificate for attending this presentation or some of the other presentations, please leave your name and email in the chat. And in addition, we're going to have on our website, all the videos are being recorded today. So we're going to have those available next week. They'll be on the website. We'll also send out another email through constant contact for all the registrants so that you'll have access to those videos. And so we have 48 going on. There's really only 6 that you can attend in this one day. So thank you very much. I want to turn it over to our presenters. Thank you.
Thank you very much, Brian, and welcome everyone. It's delightful to be with you today, and we're very excited to spend 75 minutes with you. See that you've been introducing yourselves in the chat. It's wonderful. Please keep it up because we always like to know who's in the room, who our audience is. As you can see, as Brian said earlier, the title to this is Know Nothing, None. Interesting, because we're really trying to question about supervision of peer support workers. Next slide, please. You already know where you are. You're at the SHARE Conference 2023. So again, welcome and continue in the chat. Next slide. Here are our presenters. You will be hearing from all of us. Myself and my colleagues decided to do this as a roundtable because not only do we bring a wealth of experience to the topic of supervision, but we also wanted to have an opportunity to interact not only with each other, but with you, the audience, because we think that supervision is real important. It's a lot of discussion and play at various conferences, but there's so much to be said about supervision, and we're really looking forward to leading that conversation off today. Next slide, please. So we're asking you to participate in answering the 3 critical questions that really brought us to the title that you saw a little earlier. I'm just going to review them, and then we're going to have a poll that we are going to ask you to participate in. And the questions we're going to be asking you have been asked throughout the country. Many of us have had national experience training, and we've done research, and we have experience with how these questions have been answered up to today. And we want to continue that conversation with you, yet another audience. So the first question that I know personally as a national trainer, we ask people is, did you volunteer to be a supervisor? Did you volunteer to supervise a peer worker? The other question we're curious about is, and once you got that responsibility, were any other responsibilities removed from your plate, as we say, to allow you to have time for supervision? And the third question that has been added to our discussion about this topic is, and as a supervisor, what training in supervision and supervising peer support workers have you received? Next slide, please. So this is a poll question. The poll is going to pop up, I believe, somewhere, so that you can answer, did you volunteer to be a supervisor? And I'm not the poll person, so I believe there it is. So take a few minutes to answer the questions. Again, the first one is, did you volunteer to be a supervisor? The second is, were any other responsibilities removed to allow you to have time for supervision? And the third, again, is, what about that training in supporting and supervising peer support workers? How much training in supervising have you received? And although we have a fourth question in this poll that's not part of the 3 critical questions that we're going to be talking about primarily, we're also curious about whether or not people in the audience have had a chance to look at the NAPS guidelines having to do with peer support work and peer support supervision. I think people have answered. It's nice to see that we're experiencing a shift in some of the answers, kind of evenly divided between, did you volunteer to be a supervisor of a peer support worker, or did you not? And moving on down, the most familiar answer is usually nothing. Thus, no, nothing. And yes, none. So that is in line with what our experience as trainers and researchers have been. And so that's the conversation we want to have with you today, because frequently we find, as we talk about supervision and how to do supervision, that the elephant in the room has to do with these three questions. Next slide, please. I think the one after this. Yeah, we have to go through our poll questions again. One more. Okay. And Rita, I believe I'm going to hand this over to you to have us start off about talking about the unintended consequences.
Thanks so much, Joanne. And I was surprised at the poll. We had a lot more people who did volunteer to be supervisors than I would have thought. So that was really encouraging. So I'm Rita Cronice, and I'm not a supervisor, but I am a consumer of supervision, if you will. I've had some terrific supervisors through the years, but I want to focus on one experience in particular that I think directly relates to these three questions. At one point, I worked as a peer support specialist in the VA. My supervisor was a social worker by training, and she had her own very heavy caseload in addition to supervising 3 very rowdy peer specialists. And I'm sure that she was voluntold to supervise us, which way back in the day, the VA made those kinds of assignments. It was just really typical of the way things worked in the VA. And I recall from my supervisor a real lack of patience with those of us who were peer support staff. And in hindsight, I didn't realize it at the time, but it was probably because she was still carrying a full caseload of her own. And working with us took time away from her own, what she felt was, her biggest responsibility. So there was frequent friction around the things that she assumed we already knew, particularly about things like dual relationships and boundaries, even though none of the 3 of us had ever been trained as social workers. And on this other side, our supervisor had no idea how we had been trained in our peer specialist training. So I do remember how uncomfortable this particular supervisor was whenever we shared our personal experiences in recovery, whether it was with the veterans we were supporting or other staff within the VA. And in supervision sessions, one of the things that she frequently focused in on was not setting people up to fail by giving them false hope. That was always the mantra that she came up with for us. And the hierarchy was one in which we couldn't really question our supervisors, so there was never a lot of discussion about the reality of recovery and helping people to choose what it is they want to do and finding their own pathways to achieve it, or the boundaries that might be different between social workers and peer specialists, or really any real chance to learn from each other through co-reflection. But to be fair, this experience was back in 2007, and I was among the first 100 peer specialists that were hired into the VA, so it was still a learning curve for everybody. I do know that things have changed a great deal since then. I've known a number of peer specialists in the VA who just love their jobs and are doing great.
Where are you employed?
So anyway, I think it's really important to look at that because supervisors in any setting that are incorporating peer specialists for the same time are going to be wrestling with many of the same issues I think that we were wrestling with our supervisor in the VA. And to be open, there's just to be open with peer support in other disciplines. And really the biggest thing is to validate not only the wisdom of the lived experience of the peer specialist, but also for us as peer specialists to really validate the wisdom of the supervisors and what they're doing. I think there's, things that go both ways and really need to. So now I would just like to invite all of you in the audience to think about the 3 questions. And in the chat, just maybe add one anecdote or something that you can think of that you could quickly add about the unintended consequences of either being directed or mandated to supervise if you were, or if you volunteered yourself and what that was like. Absolutely, because our poll showed we had, kind of a split decision there. So either way, what your experience was. or the experience of not having anything taken from your workload, or the lack of training that you might have received about supervising peer specialists. And while all of you are adding to the chat, I would like to invite my co-presenters to also respond to this question. What are the unintended consequences when these three questions are answered? No, nothing, none.
Thanks for that, Rita. I just want to pitch in a little bit from my own experience. And I'm so happy to see that there is that shift, because I too have been working in this arena for a long time. And since 2007 on, most frequently the answers were no, nothing, and none. And it's not unique to peer support workers. I mean, I do have to say that often in organizations, people get voluntold to be a supervisor, and frequently is based on them being, excellent practitioners, excellent workers, and, have a presentation that says to upper management or whoever gets to make that decision, you would make a great supervisor. And that kind of acknowledgement is very hard to turn down sometimes. The other thing we know is that most organizations in behavioral health are running on kind of shoestrings. This arena is not flush with, money for private jets and, conferences. I think I'm pretty accurate in saying that to all of you in the audience. So often, I know I've experienced it personally, you become a supervisor, and the expectation is that you're going to figure out how to do that. And what I've seen is many supervisees talking about the fact that they really don't get supervision. That, even if they have a scheduled supervision time, it doesn't happen because a crisis happens or the supervisor gets pulled in to some other meeting, etc. So, that's what I've witnessed as the unintended consequences. And I'd like to pass it on to one of my other co-presenters.
Good afternoon, everyone. I believe that's me, and I believe that I'm unmuted and visible. I think we're ready to move to the next slide. I hope I didn't jump the gun. Great. So I'm Jonathan Edwards, and I'm working among 4 really wonderful colleagues. We meet at least once a week. I won't go as far as saying we're enmeshed, but we do see each other a lot. So much to the point that when I was signing off with Rita yesterday, I said, I'll see you one day soon. And when I clicked the phone down, I said, oh, I'm seeing her tomorrow morning. So anyway, that's just to let you know that we have a common interest in this work, and we talk a lot about it, and we have a lot of experiences that we bring together and have an opportunity to share on. So I was asked to talk a little bit about how our supervisors identified, trained, and deployed. And I will not pretend that I have a formulaic response to this question, and that there's one way of doing it, but I will share a couple of visceral reactions that I have to this question. And the first one is that I believe that supervisors are often identified, trained, and deployed in a whirlwind, such that I'm not even certain that the 3 questions that are the focus of this presentation are even pondered. In fact, when Joanne first presented this to us, I said, oh, right. Those are important questions. I wanted to be a supervisor because I wanted upward mobility, and I wanted to, as they say, cut my teeth and build skills. And also my supervision experience really took off when I went to a hospital system to work. And so, I was one of those people, who would have said I volunteered, or let's just say I sought out advancement, which landed me in a supervisory position. But I will say, I think this question, for me, it speaks to not just how supervisors are identified, trained, and deployed, But who we end up supervising, and I know that might sound really provocative and disparaging, but what comes to mind is an example of being at a conference in New York State about 15 years ago, and I was presenting on a panel. And afterwards, one of my colleagues ran up to me and said, "I want you to meet someone." And I won't describe the person because I believe in anonymity, but this person was brought to me and made a really wonderful impression. And I was told, "Oh, you really need to hire this person because you've never met anyone like them before." And so, long story short, they were hired. And this person has a lot of strengths. I believe in starting with the strengths, but there were also many a nightmare. And once I asked my colleague, I said, "Let me ask you a question. What sort of motivated you to bring this person to me?" And she said, "Well, I knew you could handle them and nobody else could." So in a sense, my experience of and my lens on supervision tends to be a little bit I was going to use the word pathologized. I've had some very negative supervision experiences, but yet it's become the foundation of a lot of my work. So there's an inherent tension there. And, I've seen supervisors identified, trained, and deployed many different ways, but I would probably leave the training out of it. Although me and my colleagues really work a lot on developing training, it's often the case that supervisors, particularly in the human services, do not receive training. Usually they're identified. That's a really nice word because I think it's more of being told and not even voluntold, but just you're going to do this. It happens a lot when there's restructuring, when things are moving around, when one manager may get really overwhelmed and need to spill over some of their responsibilities to another person. And unfortunately, I don't have a really cheery story to share with you all about how to answer this question. But I would say that we really have the opportunity to change this paradigm. And I think we're doing that even as we present here. And I think that's one of the reasons that we're here. We do a lot of work in bringing together supervisors, both of peers and non-peers, holding focus groups, conducting research, developing curriculum, working with academic institutions, working with people who are actually on the ground doing the work to really try to learn what supervision is about and to try to some extent, manualize the practice, as well as, get a sense of what is good supervision at the end of the day. Unfortunately, and I'd really be interested in hearing some of your or seeing you put your responses in the chat to what your impressions are of how supervisors are identified, trained, and deployed. As you're doing that, I'll just add on to say, I think as I age, I tend to be more transparent and less diplomatic. And I'll say that with the peer support workforce of which I'm a part. And I used the word before, pathologized. I think when someone is not particularly work ready and they're thrust into the arena of the world of work, it's sort of like what I remember at a children's birthday party, the game Hot Potato. They get passed around, take this person because you could handle them. And in one sense, it feels flattering. In another sense, it feels a little bit sad that we regard coworkers as such, even when they come and they have some strengths yet to develop. And so I just kind of wanted to share that to say that I've seen people commodified and disparaged and their weaknesses focused on in the realm of supervision. So please put some comments into the chat. I'm seeing something about a certificate, but I'm not seeing much more beyond that. So how are supervisors identified, trained, and deployed? If you would just pop some of your responses in the chat, that would be great. So I'm not sure if Rita and Joanne gave out candy, but I'm not getting any answers. So I'm assuming that there might be something different going on. Or if somebody wants to just unmute and chime in, should I do my part now, Amy? Wow, Amy. I guess you're saying play that music and get him off the stage. Hurry. Yeah, Amy, why don't you jump in, and if somebody
No,
wants to
not at
circle
all. I
back
would
later.
never feel that way, but I figured while people are thinking and typing, I can kind of share a bit and then go back to what
Yeah.
folks
Well,
are.
now the answers are coming. So you did something to make this happen. So thank you. So Bonnie says, I think the problem is that most supervisors are not trained or deployed effectively. I would agree. David says experience as a lead CPS before supervisor. So it sounds like you had a career ladder. Congratulations. Sharon says, I run a number of support groups, and based on my success with that, I was thrust into a supervisor's role. It's a different skill set, I'll say. And Jana says, I'm sorry, I'm not a supervisor. Don't be sorry, Jana. Gita says, yes, Sharon, this is a common issue across employment domains. Great programmers get taken offline to do administrative work for which they are not qualified or trained. And I'll read the last one and then I'll pass it to Amy. Katrina says, supervising requires built-in leadership mixed with on-the-job experience. And I like to refer to supervision as that very delicate dance, striking the balance between being compassionate, understanding, being able to discern the differential needs of people without creating a double standard. And it's possible, but not many people are really going to sign up for that. Anyway, Amy, take it away.
Thank you, Jonathan. So I really appreciate, firstly, being invited by this group of colleagues to talk with you all and spend some time today thinking about and discussing the ways in which supervisors are identified, trained, and deployed. And much of what you all shared in the chat thus far has been my observation and experience as well. So I feel like I'm in really good company. I've been a supervisor. I am a supervisor. I'm also a project director, a trainer, and a consultant, and my areas of interest certainly include supervision. So the majority of that experience has been within nonprofit organizations that are community-based and are doing kind of a wide array of services, providing different types of elements of service to people residing in our communities that are either through peer-run organizations or organizations that employ and hopefully train peer workers and supervisors, although that's not always the case. And what I've noticed is that the majority of supervision that I've seen prior to training and prior to doing consultation has really been very administrative supervision, so that those folks who are in supervisory roles are doing a lot of supervision that's based on outcomes of the programs that they're supervising within. So looking at things like units of service, ensuring that documentation is complete, and imparting and kind of upholding agency policies and procedures. What I've also noticed a lot of is that there's the majority of supervisors that are considered licensed, qualified mental health practitioners, which doesn't always mean that the supervisor also has the experience of being in the role of a peer support worker or having the shared lived experience of a mental health or behavioral health condition. I wanted to go back just a moment to when Rita started asking you all to think about questions and put your responses in the chat, because I think something that came through loud and clear is that supervisors may not always understand the role of the peer support worker, and other members, especially in an interdisciplinary team, may not understand or value the role of the peer support worker. You also indicated in the chat, which is part of what I was considering for this slide, that there is a certain added pressure upon us when we're responsible for supervising others. So the jobs we do are stressful in themselves, and then adding the responsibility and accountability of supervising the work of other people can feel like a real added demand, especially as one person noted, if there's a history of trauma or a bad experience with authority, that can really arise and serve as a challenge or a barrier in supervision, as well as people's kind of vicarious trauma from working with individuals who are experiencing really heavy life circumstances in certain cases. The other thing I've observed about the identification, training, and deployment of supervisors is that the supervision is not always tailored to the peer worker role. And so going back to that idea that many supervisors are skilled in administrative types of supervision, they do a good job training others in the policies and the procedures, and they may even do an excellent job at what's traditionally been referred to as clinical supervision. But we think in our experiences that the ideal is supervisors would be deployed in positions and providing supervision that's based on the principles and the practices of the specific job description and the discipline of the worker. So just like you would supervise a social worker in the practices of social work, you should be supervising peer support workers in the principles of peer support and tailoring that supervision to their job description and what the expectations are clearly designated for that role. So I think that that's all that I had for my bit, and I'll turn it back to Jonathan if you want to wrap up the slide, Jonathan.
Can I just jump in a minute, Jonathan? Because both of you said things that reminded me of why this conversation is important. And Jonathan, you spoke about transparency, and Amy, you brought forward the fact that frequently there is a mismatch between the supervisor and the supervisee. If the supervisor's never been a peer support worker, it's almost not fair to them to try to figure out how to help someone do that job. But the other thing that I want to get out into the atmosphere is what I've run into frequently is that because peer support work is relatively new, yes, it's been around as a paid position for more than a decade. It was around way before then, as we all know, but people are still getting their feet under them in terms of how does this work. And what peers have told me is that not understanding this background, which is a lot of supervisors did not volunteer, they were voluntold. Many of them had nothing taken off their plate. And certainly when we started this journey, virtually none of them were getting training in what supervising a peer support worker might look like. And what I noticed, and I talked with my colleagues and peer support workers, is that many peer support workers understood that to mean there was something wrong with them. So when they had a scheduled supervisory appointment at 1 p.m. and they showed up eagerly to talk about what their work was and what the struggles were, and the supervisor never showed up, frequently they did what we all do, which is, oh my goodness, what did I do wrong? I must not be doing a good job. My supervisor doesn't like me. You know, we all have that tendency to personalize our perspective and our experiences in the world. And so without this broader understanding that supervisors frequently didn't volunteer, they were put in that position, and frequently they don't have room on their plate. We're bringing it forward and making it visible because we want people to think about, oh my goodness, so I've got to be transparent about that. I really need to tell my supervisee, you know, I'm happy to work with you. I have a full plate. There may be times when I'm eager to talk with you and I get pulled in 6 different directions. Let's figure out a backup plan for that. Let's figure out a contingency and work through that issue. And also the other thing that I hear frequently when I'm training is my supervisor isn't a peer, doesn't know what I'm talking about, wants me to do non-peer related things. I'm not the medication police, et cetera, et cetera. So to understand that it's not uncommon for supervisors to not have done this job would help people, we hope, to move to that place of mutual learning, mutuality, and be open and curious and say things like, I know I've never done your job. I'm not a social worker. I guess you've never done my job. I'm eager to learn from you. Let's talk to each other so that I can understand where you're coming from and you can understand where I'm coming from. So just wanted to throw that out there for people to think about or respond to. And Jonathan, I'm sorry, I just needed to get that out there and said. Back to you.
Thank you, Joanne. Thank you. And, now I'm going to tell on you to say that you did your dissertation on the experiences of peer support specialists supervised by non-peer supervisors. And I had the pleasure of being at your defense. And so it makes sense that you would want to share all the wisdom that you learned through your research. And I just want to also circle back to Amy and say, one of the things I picked up from what you were sharing is, and I don't know if you said this, but it's what I heard, is that sometimes people are put into supervisory positions because they have good management skills. They know how to take care of things. They know how to put out fires. They know how to manage people, but they may not understand the work. And they may have really, really good intentions also. So I've seen a lot of situations that are benign, or benign in the sense that, the supervisor or the authority figure is not out to hurt anyone or to do damage. But there is definitely a disconnect between, good management and, understanding of what the mission and the purpose of the work is. And I've seen, really well-paid, respected managers who knew nothing about the work they were supervising, but they were smart enough to get good people around them. And so I guess that's a strategy as well. But oftentimes we don't see it pan out like that. Some of us have worked in hospital systems where we see, I just learned that the peers in a big New York City hospital are now working under psychology. Before they were under social work. Before that, the director of creative arts therapy was trying to sabotage somebody else so he can get the peers under them. So, there's just a lot of, as I used the term before, commodified. And I think a commodity is something that's often objectified and traded. So I've seen that happen to peer workforces where it's like, let's, how would you like to supervise the peers? Or how about we put the peers under your division? So it sounds like really bad placement, placement as in moving, children around to foster homes without being thoughtful. So unfortunately, those connections come to mind for me. And I will then pass on to, I'm not sure who's next, but I'm going to flow out now.
I'm going to jump in quickly because I want to talk about, to give some hope. So I have been working in peer support supervision for about 11 years. And before that, I was a peer support worker. And now, although I'm a social worker, I maintain my peer support specialist certification in the state of New York. And the reason I tell you all this is because we're going to bring Rita in to talk about peer values. And one of the biggest peer values is mutuality. So I like to think of myself as a disruptive supervisor. I have group supervision. I'm the contact person for the whole public health system, but I jealously hang on to one program here. It's called the Peer Health Coach Program, and it's a boutique program where people are deployed to the various hospital facilities to give groups in the inpatient psychiatric units. This is hard work. And there's a great deal of compassion fatigue, vicarious trauma. And when we get into individual supervisions, I find we don't need to talk about people's diagnosis or whether their experience is due to their, I'm going to use air quotes, illness. I just want to give one example. I have someone who's very new to the work who it was uncovered in supervision that he had very negative feelings about himself because he's heavily tattooed, which he associates with gang membership and prison. And even though social workers are guided not to share too much lived experience, as a peer, I refuse to operate that way. And I was able to tell Hyro, but I have several tattoos and I have not been involved in gangs nor have been in prison. Tattoos are your art and you should not feel ashamed. If they were a problem, we would not have hired you. And it just feels so good to share lived experience. It doesn't have to be lived experience of mental illness. You could say, I have a kitten, or I like classic rock music. And again, mutuality is the most important value for me, perhaps other than voluntary peer support. Rita, why don't you hop on and give me a little hand with this?
With voluntary peer support, I'm voluntary.
No, with the
choice. You know, people make choices. Yeah, people make, one of the most fundamental values is that people have choice and they're not forced into doing things. Another one of the values is that peers are open-minded and not judgmental and really don't take at face value. Suppose, you know, somebody is in their chart diagnosed as one thing. I really believe that peers should not be looking at people's charts before they get to know them, because that clouds their ability to be non-judgmental of the person. So there's lots of areas where being mutual and reciprocal, being change agents. So that's making sure that people that you educate and advocate for the things that go along with peer support. And I have another slide a little bit further on about the national practice guidelines, and I'll put a plug in there because our work group actually did work to add to those national practice guidelines what the role of the supervisor is in helping peers to be able to embody those values. So there's a whole area within those national practice guidelines that of all of us, Jonathan put his heart and soul into. We all contributed, but he really made a lot of contributions to that. And it's really a great resource. I know that in the poll, I think it was like 25% knew about the practice guidelines and then 75% did not. I think there's a slide here in between though, because I think I'm jumping ahead over one area that we wanted to talk about. So I'm going to bring that up. And that's how peer values are understood, identified, and supported. So I am talking about this area. And here we have the national practice guidelines. I've sort of mentioned a few of the guidelines, but here is the website for the National Association of Peer Supporters, where the practice guidelines live. It's really a good practice to do things like potentially take one guideline at a time and use it in supervision, so that really both the supervisor and the peer specialist are really practicing each one of those values, core values, and the guidelines that go with them on a regular basis. So that's one area. Another big area is core competencies, and SAMHSA has the core competencies for peer specialists. So between those two areas, between the core competencies and the practice guidelines, and then any kind of ethical code of conduct that your state or your organization might have, between those three, that's a really good place to start with really understanding what are the practice guidelines and what are the core values of peer support. Any questions about that? And again, the poll was that. Let me see if I can pull that poll back up. Sharing the results. So we had 39% have reviewed the national practice guidelines and 61 of you have not. So if you haven't, I really encourage you to do that.
And it would, I think, important for Gita and Rita, if you don't mind, to continue the conversation about peer values, because one of the other things we all talk about, our group of colleagues, is peer drift, co-optation, and how easily that can happen unintended. When you have that peer support worker, there might be only one of you, maybe there are two of you. My experience is frequently large organizations can hire a group of peer support workers, but then they tend to assign them throughout the organization. So as a peer support worker, frequently you're alone. And there's a lot of pressure. You know, we're as a species, we're social people, we're group people. We like to get along with the group. If you're the peer support worker and the rest of your colleagues come from other professions that might not have lived experience or might not want to disclose lived experience, there is going to be pressure to join the mainstream, to be like everyone else. And as Rita started talking about, and I really want her and Gita to talk more about, those peer values that are not shared across all the professions that might be working together as a team.
Well, the first one, of course, that comes to mind is just the sharing of your lived experience, because most of the clinical professionals, the licensed practitioners, they're actually taught not to do that. And they're taught to keep sort of a professional distance so that there's not the attachment that goes with that. And it's very different for peers because we go in there heart open and we really do share our stories and we do encourage them to share their stories. It becomes a very mutual way of learning together. And that's just really one of the big differences between peer support and the other professions. And like I mentioned, my supervisor back at the VA, she was very uncomfortable with me sharing my story, very. And I think it's just because that was not how she was trained. And I hear the word oversharing quite often, where it's not really oversharing, it's really the sharing that peer specialists do. But it's seen as something that's not, and that is what is in alignment with the values of peer support, but it's not seen as what's right within many of the environments and cultural climates of many organizations. Gita, do you have more?
I have a couple of things. I was in a meeting this morning with, we have a quarterly forum for supervisors of peers in our substance use programs, and they're usually social workers or addiction counselors. And we were talking about documentation. And as I went through the documentation, I noticed that many of the peer support workers were not putting in their notes as an intervention, peer support worker shared lived experience of whatever, because this is the intervention. And the other thing they weren't doing was introducing themselves to participants and saying, hi, I'm Guillermo, I'm a peer support specialist. Do you know what that is? No. I'm someone with lived experience. I've been through what you're going through, and I want to talk to you about some things that have helped me begin and maintain my recovery. And so, yes, this is top of the line necessity. And these voluntold supervisors from clinical disciplines often are uncomfortable with that, but there is a thing called sitting with your discomfort, and this is what they will just have to do. I always tell this because I feel like I'm so lucky in one respect. Public health system is heavily unionized. So our peer support workers are in their own union, the social workers are in their own union, and the interns are in their own union. So if you ask a peer support worker to do something clinical, like a suicide assessment or a safety contract, or something non-clinical but ridiculous, like distribute snacks or make coffee, the peer support worker can grieve it with the union, and the social worker who may be looking on as the peer does that suicide assessment can grieve that out of title work with their union. So except for the lockdown during the pandemic in New York City, when it was all hands on deck and everybody was working out of title, I was calling the families of the deceased. It was just unreal. But Metropolitan Hospital asked me, could they deploy their peers to the Helping Healers Heal unit to provide supportive counseling? And that I thought was an incredible win for peer support workers here at H&H.
Great. Thank you, Geeta. So I'm going to move on to the what's a supervisor to do. I think this goes to Joanne.
It does. And thank you both for sharing those stories, because the more we share those kind of experiences, the more folks realize, oh, that's what happened to me, and I thought it was just me. And normalizing these kind of intersections where we haven't quite made the match that needs to be made between our profession as peer support workers and other professionals is really an important intersection, and needs to be talked about, and needs to be talked about in places where you can get support. So I'm going to talk about what's a supervisor to do, because as Jonathan mentioned, I was blessed with a gift of having to do a dissertation for my doctorate. And I will share with you the reason I got my doctorate is I wanted to have a chair at the table when these issues got discussed. And I wanted to have some of the clout behind it that a doctorate allegedly brings. I keep forgetting I have a doctorate, and Jonathan reminds me, and I'm very grateful to him for that. But so I did spend a lot of time with peer support workers who are being supervised by non-peer supervisors. And I will say to you, they love their supervisors. There are great supervisors out there. There's no question about that. Whether they were voluntold, whether they had anything taken off their plate, people who sign up to do this work to help other people have huge hearts. And it was on display as I talked to people across the country about, what was going on there. So when I talk about attitude adjustment, what I mean by that is the one skill that was really important for supervisors who weren't peers, who got voluntold, who were in a position to manage something that they'd never been asked to manage before, is when their attitude got internally adjusted from, oh my God, I don't know what to do, to, you know what? I'm open to learning. I'm curious. I'm okay with this. To respect and to be curious about peer support work really made all the difference. And that's easy for some people to do, maybe not so easy for other people to do. I will share with you that folks who felt that they had to know that it was their job as a supervisor to figure this out ended up micromanaging in ways that peer support workers did not find helpful, because the non-peer professional might not have known what the job was, but was desperately trying to do a good job and didn't work out so well. So that openness of attitude, that public facing, this is great, I got your back, I know what you can do if I just let you, if I just get out of the way. That's the attitude adjustment that we're talking about. And Modeling transparency, being that person on the team who can manage our own anxiety. I mean, that's really what gets in the way, right? You're a supervisor, you feel responsible for everything, in control of nothing. When you do your deep breathing and say, look, I'm trying to understand this. And when you share with your colleagues, we all have a lot to learn from this new member of our team, from this person who does something slightly different from what we do. Modeling that transparency is not only a peer value, but it really goes a long way to helping the entire organization and the entire team take that next step. And it goes along with what I talked about earlier, mutual learning. That's how we all learn. We learn from one another. And to be open about that helps. Many of us who have gotten academic credentials can frequently feel like, I'm supposed to know all this. I learned it, I remember it, I don't know what to do with it, but I'm supposed to be an expert now. I'm supposed to know what I'm doing. The reality is we all learn as we go along. Experience is the greatest teacher. Back in the day, even before my time, when there's apprenticeships, that was the expected way to learn. You weren't sent to a school to read a book. You were paired with someone who was doing the job that you wanted to learn. And that's how you learned it. And we've kind of gotten away from that expectation and put a burden on all of us that we're supposed to know what we're doing at all times. Never going to happen. The longer you live, the less you know. Take it from me. But the other thing that I want to share with you, if your answers to our 3 critical questions were no, nothing, and none, is build a support network. If you're a supervisor, you need a network. You need other supervisors to talk with and share with and get ideas from. If you're a peer support worker, you particularly need a network so that you have other peers who are doing your same kind of work that you can talk to and go to and say, "Oi, I just was talking with someone and this came up and I've never experienced that before and I don't know if I handled it the way I could have, should have. What do you think?" Et cetera, et cetera. So I want to engage my colleagues back into this discussion because I know all of us have had this experience of trying to figure out as a supervisor, what do you do? And those of you who are in the audience, we really encourage you to put in the chat some of these experiences that you've had. So the more we share, the more transparent we are, I think is a blessing to the whole community. So I'm going to invite my colleagues back in, if you will. Cats got their tongue.
Sorry about that, Joanne. I was talking away on mute.
And been there, done that.
I wanted to just take a moment and kind of highlight some of those important points that came up in your last part and then previous comments in the chat, as well as our colleagues. It really sounded to me like there were at least 3 or 4 suggestions made that we'll probably get to in another couple slides, but I didn't want to lose them. So this idea of co-reflection for peer supervisors, being able to talk with one another and kind of bounce ideas off of each other, it can be a lonely experience if you're doing this work and you don't have your own supervision. So finding opportunities to connect with other supervisors might be helpful. We also heard people talking about linking peer support workers to one another. So especially if you're the only peer support worker in your team or your organization, even That could be isolating. We did mention supervision based on the job description, so being sure that that's very clear and the expectations are understood. And then getting training in peer principles and values if you are a supervisor who hasn't been a peer support worker yourself. So hope that's helpful, Joanne. I just wanted to share my notes.
Thank you, Amy. And if we go to the next slide, I think that is kind of where we're heading to begin to wind down this presentation. You know, what are the pathways? What are the remedies? We suspect that you and the audience have intersected with a variety of experiences, either as a supervisor or peer support worker. We encourage you to either raise your hand or particularly put in the chat, you know, what have you discovered that has helped you get good supervision, the supervision you've always wanted? What's helped you as a supervisor be that person that you want to be as a supervisor? And Amy, I'm going to hand it back to you to kind of moderate this, if you don't mind.
Yeah, I'd love to. So I shared a couple of the ideas that came through in the chatter and the discussion, and we're really interested in hearing more about what are those remedies and pathways to help support not only the supervisor, but also the person who's being supervised, because ultimately the goal is to ensure that the person who's receiving supervision has opportunities for professional development, potential career advancement, and that they're providing support in a way that benefits the people who are seeking it. So supervision is multi-layered and multi-dimensional. And so if you were a person receiving supervision, we'd love to hear what were some of the remedies to know nothing, none. And if you're a supervisor, what were some of the ways in which you were able to kind of bolster yourself, perhaps, in order to do the important work you're doing? And any of our presenters can also jump in as well. So Jerry, thank you for sharing. What's helped Jerry is being transparent with the supervisor. That's wonderful. Identifying some of the areas in which there's a challenge or a barrier or a struggle being a supervisor, and then seeking out the training and guidance to become more proficient. That's wonderful. You're kind of hitting all of the important parts that we're discussing. Jana says, need to give the supervisor a break and ask more questions about how to support one another. And that's fantastic, Jana. I think one of the things that we've practiced and has been helpful to us in the past is doing things like, you know, collaborative agenda setting, ensuring that, you know, both individuals in the supervision relationship have the opportunity to describe what's most important to them, and keep kind of track of things that may not get attended to immediately so they don't fall off the plate. These are great comments, Katrina, using the review tool, allowing the peer employee opportunities to set the tone. So a really objective measure of performance is the fair way to help evaluate people versus some ambiguous or subjective measure, or it's done so infrequently that the person is blindsided. Sharon says seeking out educational opportunities like today. Thanks for coming, Sharon. Rita, encouraging group supervision with peers in the lead. Gita, supervisee brings the agenda. Love that. And learning what not to do by having a good supervisor in the past is great. Jonathan, did you want to take over and kind of round out the strategies part?
No, I actually was more in listening mode and I didn't put in anything. So just for the sake of time, I will forfeit that. Thank
Okay. All right. Shane.
I see Shane has a hand up.
Thanks, Gita. Go ahead, Shane. You can unmute whenever you're ready.
Hi, thank you so much. I just wanted to share that I love this whole thing. I supervise a group of folks that I am not a peer with them. I did not experience the trauma that they went through. But I did I have supervised people for many, many years. And so this experience has been very different. I've had to really grow and learn. I've had to, you know, become more empathetic. I've had to, and I think the way I think of it is I'm not really the supervisor. I'm a team member, right? We're all in this together. We're working on a project together. I may have some resources that are helpful for folks when they need it. They look to me as, you know, a member of the team, but also someone who has a bit more experience in the administration of a project that they don't have. And so that's the piece that I bring to the team, is the administrative piece. And so I just think of myself as a resource person. And yes, once in a while I do have to say, you know, like, you didn't do something, or you are late, or, you know, I do have to do that every once in a while. But really I feel like my job is just to be a good team member and to offer resources when people need it, or when I see that they're struggling with something. But I really, like a lot of the comments that are happening right now, I really look to them to come to me. We're all adults, right? We're all adults and we have life experience. And if you need something, I try to leave the door wide open to come and talk. Let's talk about it. Let's see what do you need? What do you think? What do you have already at your fingertips? And how can I help? That's kind of how I look at it.
Thank you, Sheen. Okay, thank you so much. And I'll turn it back over to Jonathan.
Thank you, Amy. So we wanted to share with you a new and relevant resource. It's several months new. I once again had the privilege of co-editing this collection with Rita Cronice, Gita Enders, and Dr. Joanne Forbes, all of whom are here. And so we are working together on a workforce and supervision committee. We've been meeting every Monday morning for several years. And after doing a 6 months learning collaborative that was funded by one of our sponsors in the community, we thought about what the next project would be. What we did was we did outreach to all of the presenters from the past 5 years of conference presentations at the National Association of Peer Specialists. And what we did was we curated all the submissions. We wanted to create narratives from workshop content with chapter overviews that were written by all of us to really offer a resource that brings together work by peer specialists and supervisors for peer specialists and supervisors. And so it aptly has the title, What It Takes, Wisdom from Peer Support Specialists and Supervisors. I'm really proud that we backed away from a very prestigious academic publisher who actually wanted us to sort of hand over the rights to our content and also price the book at a point that would have been unaffordable by many of our stakeholders. And so we chose to self-publish through Amazon and to have this as a fundraiser for NAPS. And so I think we're doing pretty well. You can order the book through Amazon. I was looking for a QR code, but if you just go on Amazon and type in What It Takes, this will come up. The book is $26.95. It's certainly well worth it. In pages alone, this is about 460 pages. And as I said, it has many presentations that are summarized and has actionable guidance that I think would be helpful to many, if not all of you. And the Kindle edition is $12.99. But if you're anything like us, you'll probably want to have the hard copy because this actually does look nice on a coffee table. Skeeter, I think you're up.
Next slide. So now we only have a couple of minutes, but I want to thank everybody for joining us. A remarkable turnout. We love to address supervision of peer support workers. And so now is the time, if there are any questions, comments, you can unmute or drop them in the chat. We would love to turn the rest of this time over to you.
Hello.
Hello, Joseph.
How you doing, folks? My life has not been easy. I've gone through a lot of situations during my life. It's taught me a lot. I've been through operations and near-death situations in my life. I study and read off of books from the library and online courses. I also volunteer. I'm a peer connector now in a recovery cafe out here in San Jose, California. I work along with Tanya Brista, who's a supervisor and teaches the classes in there for us to become certified, to become workers. So now I work and I get paid to learn and watch and learn and read and study. It's challenging, but I've also been looking at opportunities to go to college out here at Evergreen, maybe City College or De Anza in the future. So I've been encouraged to do that. I've been straightening out some of my bills so I can get some Pell grants and some financial situation straightened out to go to college in the future.
Well, this is, oh, I'm sorry.
Go ahead.
No, I just want to say this is a wonderful story. I read some of your pieces in the chat, and peer support is, Jonathan is clapping, peer support can be such an elevating place to be. And we always talk about professional development and personal development, and you are the embodiment of that. I think this is very exciting.
Yes, I lived in tents and back of vehicles out here in San Jose. San Jose has been some of my best years of seeing the homeless out here. I've seen kids thrown out in the streets that their parents are irresponsible and not taking the responsibility of being their payees. And they have no idea how to go collect their checks and how to get on SSI or anything. And it's like, you know, it's, we just had a town hall meeting yesterday down there at Recovery Cafe, and we talked a lot, and I shared a lot of information with that town meeting too. So a lot of the people were overwhelmed at what I had to say. So this county out here is going to become, in 2025, it's be civil amendment that the family courts are going to start taking care and taking situations and answers filed by 2025. So that's amazing right now. So we're looking at that to become an effect in 2025.
This is great and very forward-reaching. Thank you so much. I think we're out of time. It's been wonderful spending time with you. Our contact information is on the screen, and you can, Jason, Robeson, and Brian know how to
I brought
outreach
down
us.
a few of your names, believe it. So I get links all the time from Tanya, and I'll be coming back into these chats in the future. So yes, thank you.